What are we doing wrong? Better yet, what are we doing right? And so, like, I'm just like, I have to listen to it all again. I had hoped to do it this morning, but I didn't sleep well last night, so I stayed in bed a little bit longer today. But I'm gonna go over and summarize the latest research, but there will be a lot more. Obviously, it's going to be the lead story in our upcoming IC Optimist magazine because, like, literally, it's the most exciting time of the year for us. Before we do that, let me introduce myself. My name is Jill Osborne. I'm the president and founder of the Interstitial Cystitis Network. I'm the national IC support group leader. So if you struggle with bladder symptoms, if you have bladder pain, if you have pelvic pain, if you have any of the chronic overlapping pain conditions like IC, IBS, vulvodynia, TMJ, fibromyalgia, I am your girl. This is my job. I love, love, love what I do. I have a lot of training. So I have degrees in chemistry. I have a degree in drug development, pharmacology. I have a master's degree in psychology. And I've done this for the last 30 years. I served for about 10 years on the CDMRP research panel, of which one of the most important studies was funded by my panel. Yeah, baby. I've now timed out. I can't be on that panel right now. You can only do 10 years. Hello, Jennifer from Janesville, Wisconsin. Hello, Gay. I'm pretty good. I'm feeling pretty good because I'm excited. I got a lot of things that I want to talk to you about today. I normally do these meetings on Sunday, but I also tend to do drop-in meetings on Fridays, Thursdays or Fridays. Hello, Shlomi. And it's always interesting. Sometimes we get big crowds during the live meetings. Sometimes we don't. That's okay. I'm here for you. I'm here to answer your questions. I'm here to give you some comfort. I want the IC Network to be a place where you come and receive hope and really good information. Debbie says you're in Wisconsin, awful weather. What? Not here. Weather's great here. Beautiful blue sky, winds blowing. I did a lot of planning yesterday, so I am good. So let's just get right into it. Okay, I've got my notes right here. God knows there's going to be a lot more notes, no doubt about that. So what is the American Urology Association? The American Urology Association is the largest professional organization for urologists. And for those of you who have been in medicine or been in healthcare, one of the things that doctors have to do is they have to continue their educational process. And so they earn something called continuing medical education credits. And so at the American Urology Association, you're going to have about 20,000, 25,000 urologists from around the world gathering together. It was in Chicago this year, it's still going on today. But obviously with COVID, there are those of us who participate virtually also. AUA has always had a 2-hour session on IC research, and it's like a science fair. So literally, if you went to a children's science fair, you would walk in, you would see all the posters they've made, and the child would be standing in front of the poster and would be taking your questions. Well, that's what a poster session at the AUA is. Literally, the researchers are standing in front of these big, beautiful posters around the wall, on the walls around a room. For about a half an hour, you walk around, you look at all the posters, you have a chance to ask questions, you have a chance to read them, and then they then discuss them in what we call a podium session. So the researcher can now come do a slideshow. It's usually about 2 or 3 minutes long. They share their data. And most importantly, it's a bit of a, what do I want to say? It can be rigorous. There can be very rigorous, challenging questions. Although there was only one this session that was a little strange. But other than that, it was fabulous to see all these top researchers supporting each other, encouraging other, challenging each other, asking about insights, asking about why did you do this and not that, et cetera, et cetera. So we had 12 studies that were presented this year. The first one is literally the most important one because this is the latest data from the National Institutes of Health MAP Research Network. Now, the MAP Research Network is the lead government body that's funded by the U.S. government through the National Institutes of Health that studies pelvic pain. And their research has been stunning. And the nice thing about the MAP Research Network, it was created really because they learned lessons and about some of their early work that was done and how they didn't, for example, bring in many different perspectives. MAP Research Network has a lot of different experts, a lot of different perspectives, everybody working together to try to understand pelvic pain. The research has been absolutely stunning and on point. They're the ones who discovered fungal infections in some patients who have painful bladder flares, et cetera, et cetera. So what's been the hot topic for the last 5 years, and especially in the last year? The fact that the IC patient population is academically heterogeneous. You're not all the same. We're not all the same, not even close to being all the same. There are very distinct subgroups in the IC patient population, and where research has failed is by putting apples, oranges, and bananas in the same treatment study and expecting everybody to respond the same. Of course, they don't. And this is why pretty much all of the bladder research and the new treatments that were under study pretty much failed. The early studies, $100 million worth to try to identify new treatments for quote unquote this mysterious disease called interstitial cystitis, failed. Okay, why? Well, because we now understand that for most of us, our symptoms are not being caused by a dysfunctional bladder wall. Our symptoms are being caused by dysfunctional pelvic floor muscles and nerves. So the key term that we're all using now is phenotyping or subtyping. And you know that I've talked about this before. 6-7 years ago, Dr. Chris Payne said, hey, I believe that there are 5 distinct groups in the IC patient population: Hunner's lesions, bladder wall-driven, pelvic floor-driven, pudendal neuralgia, central sensitization, widespread pain. We've used that very, very successfully to help you find the best treatments for you. Now, a month ago, Dr. Curtis Nickel, who also presented research that we'll be talking about, said he believes that there are 9 subtypes. The Chris Payne subtypes were on point, but he believes that there are more. Now, getting the government to, also known as being extremely conservative, to be forward thinking like that is challenging. Because they want data. They want proof that there are distinct groups. And so in our guidelines that were released a year ago, they said, okay, there are 3 groups at least. Bladder wall driven, pelvic floor driven, and non-urologic pelvic pain. Obviously, there's a lot of, discussion and debate about these groups. But here's something. So they presented yet more data supporting that they believe that there are at least 3 groups. And I want to show you, let's see, I want to show you this picture first. I want you to look at this picture first. So these are very clear data points. So the orange, for example, is the myofascial pain group. That's the muscle group. The purple is the bladder pain group. And the turquoise is the non-urologic pelvic pain. Okay, so there you go. I want you to see that. Oh, you know what? I need to print out one more slide. Hold on, I gotta find it. A very cool slide. I took screenshots. Hold on. I gotta find this slide real quick. Nope, that's not it. Where is it? Yeah, there it is. All right. Okay. So in their study now of these 3 distinct groups. They are now trying to identify symptomology, which symptoms are specific with each group. You know, because what are we, I mean, we have to be able to here, hold on, let me grab this real quick. Okay. My jaw dropped. My jaw dropped. Okay, you want to know the leading symptoms that define pelvic floor pain? Pain coming from your muscles. What are the key symptoms that tell us your muscles are screwed up? Okay. Number 1, fluctuating pain below the waist. Number 2, straining to void. If you have to push hard to empty your bladder, that tells us your muscles are messed up. Number 3, urinary frequency. Number 4, urinary urgency. Number 5, a sensation of incomplete emptying. Okay. Fluctuating pain below the waist, straining to void, frequency, urgency, sensation of incomplete emptying. Those are the symptoms that somebody with pelvic floor muscles struggle with. Kimberly, I'm sorry to hear that. I will come back to that, okay? So what are the symptoms of a bladder wall driven, quote unquote, IC? Be prepared to have your head blown off. You know the only symptom that correlates with bladder wall dysfunction? Pain that increases as your bladder fills with urine, and pain that is relieved when you empty your bladder. Guess what? Urinary frequency is not correlated with a bladder wall dysfunction. That the frequency, according to their data, is being caused by tight pelvic floor muscles. Like, oh my God. That's mind-blowing. Wait, what? Okay, and what's non-urologic pelvic pain? What are the symptoms? There's no association with filling or emptying. So if you're one of those patients where your pain is constant and it doesn't get better, it doesn't get worse as it fills, it doesn't get better as you empty your bladder, or if you have constant urethral or vaginal pain, you are in a distinct group. So think about this for a moment. What have we always said? The number 1 symptom of a bladder wall injury trauma is frequency. But their data now has completely disproven that. So I sent an email to my colleague Jane, who runs the International Painful Bladder Association over in the Netherlands, because we were both participating virtually. So I sent her an email and I went, oh my God, wait, what? They're now correlating frequency with tight pelvic floor muscles and not the bladder wall? What? Her response this morning, and I'm sure she will not be offended if I read part of her response. Hold on a sec. Let's see here. I got to find it real quick. So they did their own research a couple years ago. Here, hold on. Is that it? I've lost it. Here we go. What you say below is exactly what I experienced with groups of patients, including a large group from the USA who had filled in questionnaires for part of a pain care research project. She looked at the responses and saw exactly the same, that pelvic floor patients struggled with frequency. Bladder wall patients did not. And she says here, it turned out that many of the patients had never had a cystoscopy. I feel certain that many patients are being given a diagnosis of IC, but in fact have other gynecological, post-surgical, or other pelvic pain disorders, such as nerve and muscle, tissue, or ligament damage. Okay, so let's go on. let's go on. So what does the next round of data show? Let's see. Here is, now you're not going to be able to read this, but I just want you to see this. So these are the distinct clinical features based upon these clusters. So this first wall, the first area is pelvic floor. The second area is bladder. The third one is non-urologic pelvic pain. If it's blue, it's positive. The darker the blue, the more this symptom is correlated. So what are our first symptoms? Pain at the entrance to the vagina, in the urethra, below the waist, during urination, with bladder filling, relieved by voiding, frequency, pain, et cetera, okay? This, again, very aggressive advanced statistical analysis shows that the pelvic floor subtype has far more bladder symptoms than the bladder wall subtype. Like, mind-blowing. And I will be going through this in depth in our magazine. So if we look down at the bottom, so here are the core symptoms. Urgency. Urgency is most intense in the pelvic floor. Frequency, most intense in the pelvic floor. Nocturia, urinating at night, most intense in patients with pelvic floor dysfunction. Okay, bladder pain, burning is more correlated with the bladder wall. And then this is supported here too. Okay, so urgency, frequency, nocturia directly correlated with tight pelvic floor muscles, not the bladder wall to the same degree. Okay. Now, I want you to look. Now, this is kind of a weird, a weird graph. And it took me a while to really understand it. Yellow is pelvic floor. Gray is non-urologic. Blue is bladder pain. Anything above center is positive. Anything below center is negative. So what's this first one? Daytime frequency. Do you see that the pelvic floor group has more a direct correlation with frequency rather than the bladder wall? Bladder pain, burning, same thing. Nocturia, clearly associated with the pelvic floor. Let's see, pressure to urinate. Okay, think about all those patients who struggle with pressure. And pressure is, I've always found pressure a difficult symptom to really understand. But I mean, to me, pressure is feeling like there's something very heavy inside of you, or feeling like you really, really need to urinate even when your bladder is negative. I mean, pressure, I find a very hard symptom to define. But again, even with pressure, look at this, not correlated with bladder wall, absolutely correlated with pelvic floor and this non-urologic pelvic pain. So what the hell is this non-urologic pelvic pain? Well, that means that the pelvic pain and symptoms are absolutely, definitely outside of the bladder. This patient is not having distinct bladder symptoms, but it might be a fibroid tumor pushing on their bladder or endometriosis. Okay, so again, this very clearly shows the bladder wall is not driving a lot of these symptoms. Here, hold on. I'll put my notes over there. Okay, now let's look at something else. So depending upon your symptoms, the next thing is what's the right treatment for your symptom? So let's think about, okay, so purple is bladder pain, yellow is pelvic floor, myofascial, and blue is non-urologic pelvic pain, okay? So who would respond best to an antidepressant? Well, what this study shows is that the bladder pain syndrome patient might, but really the patient who's struggling with widespread pelvic pain, they're probably going to do the best. The patients with pelvic floor dysfunction are not going to have a strong correlation or effectiveness from an antidepressant. That makes sense because their problem is muscular. It's not neurological. Antidepressants in low doses calm nerves down. Okay, who responds best to pelvic floor physical therapy? Bam! Patients with tight pelvic floor muscles. Interestingly, patients with non-neurologic pain. And look who responded the poorest. Bladder wall driven. Okay, who's going to respond the best to bladder installation? Well, not patients with non-neurologic pain. Pelvic floor patients, they don't do particularly well with bladder installations, but bladder wall patients do respond very, very well to bladder wall installations. And then these are bladder analgesics like pyridium, right? And so clearly it's kind of the same. In the end, this is what we know. Our treatment approach to IC for the last 25 years has been flawed terribly. Because what they assumed is that everybody had bladder wall, therefore everybody needed Elmeron, everybody needed an antidepressant, everybody needed to follow the IC diet. But we know that doesn't work for the vast majority of us. Why? Because we are a heterogeneous patient population. We're a diverse patient population. 85 to 90% of you have muscle problems. Only 10% of you have genuine bladder wall problems. That's what this data is showing. Okay, so let's look. So here we go. Let me just go back to this poster session. In the present analysis, we extend, oh, you don't need to know all that. Let's see. You don't need to, I was done. I'll go over this. So they were looking at symptom clusters. A myofascial pelvic pain group had, here's a word for you, stranguria, like strangle, but it's uria. It means that muscles are so tight, they're kind of strangling the urinary tract. They're making it difficult for you to urinate. Let's see, is there anything else here that we need to know? So they are saying the patient's symptoms can be utilized to perform now deep phenotyping to identify your distinct subgroup, and phenotypic clusters are stable in both single pilot studies and larger multi-site studies. Okay, so again, Chris Payne uses the 5, Curtis Nickel is proposing 9, but at that federal level, they want the data to back it up, so they're at least willing to go to 3 subtypes. This is really huge. So when people ask me, why do I have to pee all the time? Why do I have frequency urgency? My answer is going to be completely different. Because normally our answer was, well, that means your bladder wall has been irritated in some way, usually by something you've eaten that day, which is possible in estrogen atrophy patients. But for a lot of you, guess what? Your frequency urgency is being driven by tight pelvic floor muscles. Okay, our next study, realizing again that we consider IC now to be a neuromuscular disorder for the vast majority of us, it's on something that we've talked about before, which is small fiber polyneuropathy. So small fiber are the nerves in your skin that have the tiniest diameter. Okay, so these are the very, very superficial nerves that live right on the surface of the skin. And they believe that small fiber neuropathy should be its own distinct subtype, or at least part of the neurologic subtype. So this is the data that they had, that 85 to 90% of IC patients are non-bladder centric. They're pelvic floor muscle. Only 10% are bladder centric. And of the patients who are non-bladder centric, 30% of us have small fiber polyneuropathy. If you struggle with really sensitive skin, well, that tells us that the nerves in your skin are tweaked. It's interesting in their research, what they found is small fiber polyneuropathy is more common in Caucasians. However, it is not found in patients with Hunner's lesions or patients with migraines. And so that's fascinating. Diabetes can cause small fiber polyneuropathy, and that small fiber polyneuropathy is now potentially a new therapeutic. There was some discussion. Rob Mulder asked about the use of systemic versus local therapeutics. So a systemic therapeutic that would calm a nerve down would be gabapentin. A local therapeutic would be a numbing agent like lidocaine. And another question that the research team asked is they wondered if small fiber polyneuropathy was related to an autoimmune disorder. The audience, the researchers were very interested in that. However, I don't think that's going to fly anywhere because when we do biopsies of bladders of patients with IC, they're normally negative. The only patients with a really strong suggestion of an autoimmune disorder are patients with Hunner's lesions. Okay, so that was another important study, which is helping us to identify nerves as an underlying dysfunction for many of us. All right, hold on one sec. All right, hold on. What did I do with my window? Oh, there it is. Okay. Okay. Let's go to the next one. So this is very interesting. You know, one of the doctors we really, really admire is Dr. Ken Peters up at Beaumont Health. They've changed the name of the health insurance. The health program. I think it's called CareWell now. But anyway, the team up in Royal Oak, Michigan, is really the most dynamic ICU research team in the world, in my opinion. And they did a study comparing bladder wall therapeutics versus pelvic floor therapeutics. They wanted to see long-term outcomes. And so they had 31 women who were in their study. 15 got pelvic floor physical therapy. 16 had bladder installations. And by the end of treatment, 67% of the pelvic floor physical therapy patients versus 54% of the installation groups reported a significant improvement in their symptoms. So here we have yet another study which shows that pelvic floor physical therapy outperforms bladder therapies. Okay. And again, why? Because for most of it, it's muscle driven. Urinary frequency was significantly reduced in patients with pelvic floor physical therapy. And it was resolved in 75% of pelvic floor patients in comparison to 33% of the installation groups. So now we have a research study which proves that pelvic floor physical therapy absolutely improves the symptom of urinary frequency, whereas bladder installations do not. Okay. However, the bladder wall installations appeared to be best for long-term pain management, but not for frequency urgency. So anyway, that's the first, let's see. So he says, if you find pelvic floor dysfunction and fix it, patients will often improve, if not completely. Patients who have increased frequency, they need physical therapy. Let's see. And one of the questions that he posed to the other urologists at the attending is, how do we convince patients that physical therapy will help their bladder? Because so many of you simply don't believe it. You don't believe that your frequency is being caused by anything other than your bladder. But now we have the data that proves it. So that's something that they're going to be really working hard on and creating the language to really help you understand the importance of physical therapy. And then another point that he brought up something that I brought up years ago, and that is the chicken versus the egg dilemma. Which comes first, the chicken or the egg, right? And for us, it's which comes first, the bladder or the pelvic floor. So which comes first, muscle tension or nerve inflammation or bladder wall dysfunction, right? And what he says here, while bladder installations might stop the symptoms, when you stop using bladder installations, the nerves wind up again and become involved again. Whereas physical therapy fundamentally changes and improves the health of the nerves. So if you treat the bladder wall, but you don't do anything about the muscles, you're going to have long-term persistent nerve dysfunction. If you treat the muscles, that creates a better environment for the nerves to calm down, and therefore you might not need, the long-term outcome is much better. I didn't say that very well. Sorry about that. Anyway, huge. Again, my mind was absolutely blown listening to the whole thing. All right. There was a paper from I think it was UCLA that where they believe that some patients diagnosed with IC and or overactive bladder and or recurring UTI might actually have something called hormonally mediated vestibulodynia. It's a common condition that affects 30% of women, yet it's poorly diagnosed and treated. The cause of this vestibular pain, now the vestibule is the entrance to the vagina. The cause of this pain is secondary to testosterone deficiency that can be caused by medications, menopause, or breastfeeding. Although the primary symptoms of HMV are associated with painful intimacy, patients with HMV often have bothersome lower urinary symptoms and are often misdiagnosed with recurring UTI. And they believe that there is a correlation here. And so they saw 107 patients. The median age was 57. Of the 107 patients, 64 or 60% were diagnosed with HMV. And that they believe that some of your urinary symptoms are actually basically, again, a nerve dysfunction of the vulva and of the vestibule. Okay, we don't really talk about that very much. Okay, here we have a study that compared. This was very interesting. It compared the use of Botox as a bladder installation, where you just put it in liquid, put it in your bladder, hold it for 20 minutes, pee it out, you got your therapy, versus using a needle to inject Botox into the bladder wall. And this study got a lot of support. A total of 220 patients were enrolled in the study. But only 40% had significantly satisfactory treatment outcomes. The satisfaction group had larger voids, lower inflammation, and lower oxidative stress biomarkers. So IC patients with less inflammation in the bladder do well with intravesical Botox. Patients with higher grade inflammation in the bladder might need more, as well as injections. Okay, so I don't know, Botox is interesting. Okay, here's something else that's very interesting. Now, Curtis Nickel, Mary, they didn't talk about it, hon. And I'm just kind of going over the research as it stands, and then we'll come back and look at stuff. Okay, so you guys, be patient with me. So Dr. Curtis Nickel is absolutely the best IC researcher advocate in Canada, one of the best in the world, brilliant writer. I read everything he writes. He's a guy who proposed, and we talked about this a couple months ago. He believes that there are 9 core subtypes or phenotypes for IC. He's being a really good forward thinker. He's exactly what we need, right? We don't want to live in the past. We want to go in the future. Well, he, for the first time, is really talking about how he believes that there are a group of patients with IC who also have recurring UTI. Mary said it's basically all an experiment. Well, it's more than that. These are validated studies. And these validated studies help us understand the intention of a treatment, the effectiveness of a treatment, and the safety of a treatment. And this data this year is really spot on. It's really good. And the big conference coming up in July, which is in New York, dedicated entirely to IC, run by the European Society for the Study of IC. Hi, Callie. That is going to be amazing. Absolutely amazing. Okay, but anyway, so Curtis Nickel, 9 subtypes. And so if you remember, he said, I think there's an allergenic subtype. I think that there are patients who are having an allergy type reaction in their bladders. And these are the patients who seem to do the best with the use of an antihistamine, right? Well, Curtis has been studying the new vaccine for bladder infection. It's called MB140. Can you imagine the millions of women who are going to be healed if they can have a vaccine which is going to prevent E. coli, enterococcus, et cetera, et cetera. And the early data with the vaccine is just phenomenal. It's so good. It's so exciting that we might actually be able to stop UTI altogether, right? Although, as we learned from COVID, there are it can change. But anyway, incredible healing prospects with the use of a vaccine. So anyway, he also believes that there's a group of IC patients who have active infection. And I've always said that too. I think it's a small group, but it's a group. That there are some patients with IC who legitimately have recurring UTI. And so in his study, he gave them the vaccine to prevent UTI. To prevent recurring UTI, right? The data was stunning. So we had 16 subjects with IC-related symptoms and recurring UTI were eligible to be included in their study. All subjects completed the 3-month vaccination period. 1 subject was lost to follow-up at 6 months. 6 subjects were UTI-free, while all 16 had a reduction in UTI compared to the year pre-vaccination. The total post-vaccination reduction was 80%. And at 12 months, 13 subjects, 81%, were moderately or markedly improved, with 8 subjects reporting significant and or a complete resolution of their long-term bladder discomfort, pain, and bothersome urinary symptoms, including those that they correlated with IC. So the conclusion for this study is that sublingual MV140 vaccine in IC patients with recurring UTI not only report UTI-free or reduced UTI incidence, but also after approximately 9 months post-vaccination, many have a total resolution of their long-term refractory IC symptoms. This suggests that some cases of IC may be based on a Th2 cell hypersensitivity. So he thinks that while the bacteria might not be pathogenic to the point that it's causing active infection and damaging cells, he thinks it might be a hypersensitivity to specific species of bacteria. And of course, we know about sensitivity because of IC subtype 5. So he thinks that there's a sensitivity process happening. That's hypersensitivity to bacteria within or entering the urinary microbiome that responds to a vaccine whose mechanism of action is to normalize or balance the mucosal immune system. So stay tuned. We need to get this MV140 vaccine down here in the United States. And I think these early studies, well, they're not early anymore. The name of the company that's doing it is Immunotech. And I'm not sure if they're already doing US studies, but I'll tell you, the Canadian studies, spot on, super exciting. I believe that the studies have also been done in Europe. So stay tuned. We're probably going to have a vaccine for UTI in the next 5 years. Okay, we're not going to do that one because that's way too academic. Okay, this is an interesting study. So Mary says we don't have this yet in Canada. No, you do, actually. You do. That's the research is being done in Canada. Is it available to the public yet? Probably not. But if you're part of the research effort, you can get it in Canada. The source of it, as he said here in his paper, that it was funded, hold on, the first North American early clinical experience trial done by, supported, okay, here we go. We're eligible to be included in the Health Canada approved MV140 vaccine for the prevention of recurring UTI. So for those people out there who have been saying, hey, maybe we all have infection, which of course there's nobody in the world who absolutely believes that, who's IC researchers. But we certainly all believe that there could be a subset of you who have recurring infection, and his study shows that. Okay, so that's very cool. All right. Now here's something else that was very, very interesting. So when we think about widespread pain for IC, that very distinct group of patients, I'm in this group who have multiple pain conditions, IC, IBS, vulvodynia, fibromyalgia, migraines, TMJ, right? I'm trying to understand the mechanism of action of why does widespread pain occur? And of course, we have a very good insight into nerve function with that it appears to be a central nervous system driven problem. So here's a research team that applied a specific test that is used to diagnose fibromyalgia. It's called a cytokine assay of in vitro stimulated peripheral blood mononuclear cells that have been previously validated for the diagnosis of fibromyalgia. And they thought, you know what, let's just test IC patients and let's see in this study how many IC patients also have markers for fibromyalgia. So they took men and women age 18 years and older with a diagnosis of IC. Patients who were excluded were taking immunosuppressants or inhaled steroids. And they identified that they all had the chronic overlapping pain conditions, right? 2 or more of the chronic overlapping pain conditions. 15 patients were in the study. 73%, 11 out of 15 patients tested positive for the fibromyalgia marker with a score of greater than 50. One patient who tested negative had been on Flonase, which would have been exclusionary. And 13 out of 14 had previously undergone cystoscopy for an evaluation of Hunner's lesions. There was no difference between the patients with lesions and patients without lesions. There's something there I still don't quite understand. But anyway, the FMA test is highly positive in the small sample of patients with IC, the majority of whom do not carry a prior fibromyalgia diagnosis. While the clinical utility of this test is uncertain, there may be potential to use this test to further phenotype patients with IC and to clarify the diagnosis in question. So that's interesting, right? That's very, very interesting. This was done by Claire Burton at Stanford University. I really like this one. We don't need to talk about that study. All right, here's a very, very interesting study that was done by Robert Evans and his colleagues at Wake Forest. You know, Robert Evans is long recognized to be our top IC doctor in the United States. He's won every time we've had a voting. He wins it hands down. Wonderful, wonderful doctor who's been working with IC patients for 30 or more years. So one of his fellows did a study to see if repeat hydro-distensions was damaging. Because we've long believed that, I mean, as he said yesterday, or day before yesterday, he said, you know, normally they don't do hydro-distensions as a treatment, especially repeated hydro-distensions over time. But there are a small subset of patients who have tried everything else, nothing worked, but hydro-distensions work. And so the question is there damage that's done to the bladder if you do 1 or 2 hydro-distensions a year over time? And they included 1,066 patients, 1,066 hydro-distension procedures, and 221 unique patients. Basically what they found is there was a group of patients where it absolutely improved their bladder capacity. For 17 out of 49 patients, their bladder capacity increased over time such that they were no longer considered low. So that helps us, again, you know, the theory with hydro-distensions years ago was, hey, if you stretch the bladder, you'll increase bladder capacity. And that's what his data found. But how do you explain those patients who've had hydro-distensions and they say it made them worse? Well, 17 patients with a non-low bladder capacity, let's see, hold on. With non-low bladder capacity at first hydro-distension. Okay, so whereas another group of patients started with a high bladder capacity and then over time their bladder capacity got smaller and smaller and smaller. So the average change in bladder capacity across the cohort that underwent multiple hydro-distensions was minimal. However, within this cohort, there were 2 distinct subgroups, one for which bladder capacity increased over time from low to non-low, and a second group for which bladder capacity decreased over time and stayed low, which may be indicative of a disease progression. Well, that was interesting. We don't need to talk about that one. And let's see. No, we don't need to talk about that one either. So anyway, absolutely brilliant session this year. Now, I haven't listened to the class on IC yet because they've been having software problems. Those were just the key research studies. But the key take-home points here is that IC is a heterogeneous population. We're not all the same. There are distinct groups, and the secret to success is figuring out which group you're in and making sure you're getting the correct treatment for your unique group. And as we learned in that first study, pelvic floor patients did not respond to amitriptyline. Who responded to amitriptyline? Bladder wall patients. the most important to me discussion in this entire thing is that urinary frequency was not correlated with the bladder wall. Urinary urgency was not correlated with the bladder wall. It was correlated with tight pelvic floor muscles. And so again, for those of you who ask, how can I reduce my frequency urgency? The answer now is pelvic floor physical therapy. Pelvic floor physical therapy. Let's see. Okay, so anyway, that's my first take on the research that was presented on Friday. And my mind was spinning yesterday. I was like, literally, I had to stop what I was doing. I had to go walk. I was just like, wait. For 30 years, we've been thinking frequency is caused by the bladder wall. What you're telling us it's not? It's caused by tight pelvic floor muscles? It's amazing. So Sandy here says, my pelvic floor therapist told me to tighten my vagina for the count of 3 and then release when I feel urgency during the night. The purpose is to retrain my brain. There you go. All right, so let me go back to some of your comments here because I missed most of them. Okay, you guys, if I missed your question, please ask it again. Don't take it personally because Facebook. So we're simulcasting now on Facebook and on YouTube. Let me open up my YouTube window here for a second. Hello, YouTube. Hey, you guys, you got a crowd in here. So hold on a sec. Let me look at YouTube here for a second. Hello, Donna. Hello, Barbara. Donna says, what about the overlapping pain? Again, it's all about nerves. Elke says, meant to say last week, after years of IC and 4 cystos, diagnosis of endometrial cancer and hysterectomy, frequency went away, but not pain if I touch the dirty dozen. Okay. Actually, all IC symptoms went away unless I eat the wrong thing. 10 years of this. So, Elke, I have to wonder if that's estrogen atrophy of your bladder wall. Thank you, Vonda. William S. had my consult with hyperbaric oxygen therapy last week for my Hunter's ulcers. Yeah. My first consult, let's see, I passed all the questions they had. Their office is working with my urologist to bolster my case. Insurance denied for my Hunters. Dang it. They said it was not tested. The person in the office said that it is normal to get denied first. That's a very, very common way. Very, very, very common. Don't give up. Social Security disability denies almost everybody. Part of it is just testing. They just hope you'll go away if they deny you. So keep going. We got the research proving hyperbaric oxygen therapy can help Hunter's lesions. Hi, Mary. Do I have any cases, documented cases? Yes. Honey, if you call me on Tuesday, I'll find it for you. If accepted, it's a huge commitment, 2 hours a day, 5 days a week for 2 months. Thanks for all you do. Hey, we had somebody here on Friday when we did our support group meeting on Facebook who had just finished their 2 months and they were doing very well. Gammy says, how do I find and get diagnosed for pelvic floor? Your gynecologist or your urologist should do an initial examination. And if they find that your muscles are tight, they refer you to a pelvic floor physical therapist. Hi, Deborah. Renata's having issues with breast tenderness with estrogen cream. You're going to have to talk to your doctor about that, hun. I don't have a good answer for you there. Okay, I'm sorry. I get breast pain too, hun. I find it very annoying. It just kind of comes and goes. They said it's a common symptom after menopause. It's one of the reasons why I wear sports bras most of the time. I just gotta, you gotta hold the girls in place so they don't jiggle so much, right? At least I do. Jennifer said, I had gallbladder surgery March 2nd. My bladder has not gone back to normal. I've had trouble emptying my bladder. Thankfully, since finding you, I was aware of pelvic floor issue. And my urologist referred me to physical therapy, and I started last week. Awesome, Jennifer. My muscles are tight in my pelvic floor. Thank you for being on the cutting edge of what's going on. I'm very hopeful this will get me on track. I'm sure it will, hon. See, the thing with the gallbladder surgery is that there's a lot of pain associated with that. So of course your muscles got tight to protect you from that pain. It's called the guarding reflex. Also, just know with gallbladder surgery, my mother had a gallbladder removed. My sister had her gallbladder removed. I have a niece who had her gallbladder removed. Diet after gallbladder surgery is all over the place. My mom couldn't eat any fats for years. Now she can. My sister cannot eat any fats at all, or she gets pain. And she had her surgery like 2 years ago. So good luck with figuring out what the diet that works for you post gallbladder surgery. Ariella says, I have a Hunter's ulcer, but I think my problem could be coming from pelvic floor. Could it be both? Absolutely. Hunter's lesions or Hunter's ulcer, are their own unique condition. So if you have Hunter's lesions, then Hunter's lesion therapy is the right thing to do. We want to treat those lesions early, because when we treat them early with lesion-specific therapy, the pain usually goes away. The problem with having a Hunter's lesion is that they're very painful. And because they're very painful, your muscles are going to get tight to protect you from that pain. That's called the guarding reflex. So you want to make sure that you're also working on those muscles to try to keep them relaxed and chill until you get your Hunter's treated. Mary says, what causes trigone inflammation, irritation? And it's the trigone referential urethra. I don't know. Trigone inflammation, irritation. See, the thing is, so you guys, the trigone is a triangular piece of tissue in your bladder where you got your two ureters, your holes for your ureters that goes down to your urethra. And it is a very hormone sensitive group of skin or section of skin. The trigone is can have varying presentations. For some people, it's smooth. For other people, it's bumpy. And so back in the day, if they saw bumpy, if they called it a cobblestone-like appearance, if they saw a bumpy trigone, some doctors lasered it off because they thought that was wrong. But then doctors finally realized, no, that's just normal for some people. It's kind of like your tongue. You know, some people have a completely smooth tongue. I don't. I have a bumpy tongue. And I asked my dentist, why is my tongue bumpy? And they're like, oh, yeah, it's just you. It's common, right? But trigone inflammation can occur if you have estrogen atrophy and you're drinking coffee, if you've gone through chemotherapy, if there's another disease process going on, if perhaps you have viral infection or fungal infection. The trigone can certainly be injured, and it certainly can become inflamed. Jennifer said, I finally bought a squatty potty. It's been very helpful for me. My pelvic floor physical therapy lady suggested that I give it a try. Yeah, we have it in the IC Network store. We had a link to it. I don't know if it's working, to be quite honest. Hold on. We are an affiliate for Squatty Potty. I think I actually disabled it. Let me look. Yeah, I took it out of the IC Network shop. Squatty Potty is basically a little stool that you put in front of your toilet. It's about 5 inches tall. And as it lifts your knees, it makes it easier for stool to pass through you in more of a straight line. If you're sitting like this, there's a kink in your bowel, and it's harder to have a bowel movement. But if you increase it, it makes it better. They have videos on their website. You can check it out. Mary says, what are the treatments for hormone-mediated vestibulodynia? Probably testosterone. It's probably going to be an estrogen testosterone cream, but I haven't studied it, and so that's a guess. Pam says, how long can you continue to use Urogesic Blue 3 times a day? I also use Azo if I'm out of my Urogesic Blue. It seems to help my burning pain inside the bladder, but also helps the frequency. I'm afraid to continually use these. Urogesic Blue, let's look it up. Well, let's see. So Urogesic Blue is a combination medicine used to treat bladder irritation, which is pain, burning, and inflammation caused by UTI. Also known as hyoscine or methenamine, methylene blue. Let's see. And it's got different ingredients to do different things. Hyoscine reduces muscle spasms. Methenamine is a mild antiseptic to prevent bacteria. Let's see. It's not commonly used for IC. It's not mentioned in the IC guidelines at all. I will tell you that right now. So what are the side effects? Most likely to cause your urinous stools to appear blue. Hey, blue poops. Blue or green poops. Get any medical help if you have signs of an allergic reaction, including hives, difficulty breathing, swelling in your face, lips, tongue, or throat. It can cause serious side effects, and you should stop using Urogesic Blue if you have dizziness, blurred vision, fast heart rate. That would be me. Agitation, confusion, pain or difficult urination, shortness of breath. Can cause dizziness, dry mouth, nausea, vomiting. I think you're going to need to look at the drug information sheet that comes with it and see what it says about long-term use. And it's just, again, you know, you're doing, honey, what you're doing is what I call chasing the symptoms. You're not fixing underlying anatomy. You're chasing your symptoms. And in the end, until we fix the underlying anatomy, you're going to struggle. We have to fix the underlying anatomy first. And that is it your bladder wall, or is it your pelvic floor, or is it another neurological issue? And as we learn from the AUA studies today, if you're dealing with frequency urgency, it's the pelvic floor physical therapy that's the most important. If you're dealing with pain in the bladder, doing bladder installations seem to be the most effective over the long term at reducing bladder pain over time. Yeah, you're going to have to look at the PDR, the drug reference. An answer is not coming up right away. Oh, here we go. Severe central nerve. Okay. Oh. FDA warning was released 10 years ago. The U.S. FDA has received reports of a serious central nervous system reactions when the drug methylene blue is given to patients taking psychiatric medications that work through the serotonin system of the brain. Methylene blue is commonly used in diagnostic procedures and is used to treat a number of medical conditions. It is believed that when methylene blue is given to patients taking these, high levels of serotonin can build up in the brain, causing toxicity. This is referred to as serotonin syndrome. The SSRIs are going to be Paxil, Luvox, Prozac, Zoloft, Celexa, Lexapro. Yeah. So I would Google Duragesic Blue and FDA warning so that you can read about that. Hi, John. Hi, Diane. Hi, Jennifer. Kimberly said, I'm glad more research has been done and continues to be conducted. IC is such a killjoy. My symptoms started a few months after a big life stressor. I was treated with nighttime gabapentin, pelvic floor, and diet. My symptoms resolved after 3 months, and I continue to keep my fingers crossed. I'll check in later to hear other stories. Okay, cool. Anne says, how can you stop your nighttime frequency? Well, what the research says is pelvic floor physical therapy is going to be the most effective at stopping your nighttime frequency. Jennifer said, my pelvic floor physical therapist told me to stop eating or drinking 2 to 3 hours before going to sleep, but it's really difficult for me to do. Sorry, guys. Allergies are really bad. That's why I'm scratching my nose here. If you have GERD, eating before you go to bed is a terrible mistake. And if you've got a very sensitive bladder, drinking 2 to 3 hours before going to sleep might make you get up a bit more. So there's nothing wrong with that advice, is to stop eating and drinking 2 to 3 hours before you go to bed. But the exception is always, you're going to have to drink some water if you take nighttime meds. Linda says, my bladder does not seem to hold very much urine. Once my bladder starts to fill, I get pressure and pain. What treatment should I seek? Bladder installations. It would be very interesting to see how you did with bladder installations, like a heparin lidocaine installation. That's what this new research study focused on. But Linda, I would also want to know if I have tight pelvic floor muscles. And if I did, I would want pelvic floor physical therapy. Here, guys, let me go get a Kleenex, okay? Allergies are really bad right now. Hold on. Alrighty then. You know, I have learned that if I drink water like this, I'm going to swallow air. See, I just did. But if I use a straw, I don't swallow the air. Maybe that's just a getting old thing. I don't know. Sorry, guys. You've had I'm just going through your messages here. So hold on. Shlomi says, I've used bladder rest at help for 2 months and then stopped. Advice maybe to try the Pure or something else. I'm suffering from heavy frequency with almost no pain, just discomfort. They found Enterococcus facilis in my last microgen test and thought maybe you can advise. Well, that Enterococcus infection is kind of notorious for causing more challenging infections. Are you following the microgen advice on how to treat it? Because if you have an active Enterococcus infection, you might need to use antibiotics, and that microgen testing would have recommended the correct antibiotic for you. I've got all the carpenter bees are making a nest right outside my window. What the? Oh, wait. Oh, that's an evil yellow. Ah, no. What? There's a hole in my roof and it. Oh. Okay. Sorry. I hate insects that can sting. And now there's a yellow jacket building a nest right there, but I'm not sure if it's a yellow jacket or not. Okay. Okay. Sorry, guys. I've got windows everywhere. Just bear with me. I see everything that's happening. All right, hold on. Sharon, update on the hyperbaric oxygen therapy. I've done 18 dives, treatments in 4 weeks. All my bladder pain has stopped. Yes. And I have been able to drink electrolytes, which normally I can't due to the potassium. I'm very hopeful. Yes, Sharon. Sharon, we have to tell your story, hon. I would love it if I could tell your story in our magazine and on our website with that update, if you'd be willing. Could you pop me an email, icnetwork@mac.com? Because we have got to show patients that hyperbaric oxygen therapy can be very useful, and it's not invasive. It's just a lot of work. Laura said, I'm open to pelvic floor clinic due to slow transit constipation. I don't think they did a pelvic floor assessment. Is it common to have bowel issues with IC? It's common to have bowel issues with tight pelvic floor muscles. I had stomach issues from 10 years old. So did I, hon. I went to elementary school with a pack of Rolaids in my pocket. A lot of that was stress. Diane says, is Cymbalta helpful for IC? My psychiatrist suggested I try it instead of Celexa. I have IBS too, so I have the overlapping pain and the overlapping, and cystoscopy showed irritated, inflamed bladder wall with bleeding and have estrogen atrophy too. Diane, the problem with Cymbalta is something called Cymbalta discontinuation syndrome. So some of these medications that the newer pain medications have a fundamental flaw, and that is if you're on them for a medium to long period of time, getting off of them is almost impossible. And it's called a discontinuation syndrome. And we wrote a big article on it several years ago. And so we've had some IC patients who have been Cymbalta and they liked it, but when it was time for them to get off of it, they basically hallucinated for a year. And so I would be, before doing something like that, I would at first be willing to do something instead like PEA, where we've got a lot of research, the palmitoyl ethanolamide, which has no side effects in the vast majority of studies, that is quite effective at reducing pain. So rather than trying something that has a very strong risk of adverse event, at least what the AUA guidelines said is do the over-the-counter stuff before you do the traditional meds, because the over-the-counter stuff doesn't have that same risk of adverse event. So I think it would be very, very interesting to try the PEA first and see if you did well with that. That's called Peora in the IC Network shop. And with the estrogen atrophy, what are you doing about the estrogen atrophy, hon? Are you doing some topical estrogen? See, now I'm going to be looking up there. I see, I got to put something to cover it so I won't look up there. So what are you doing about the estrogen atrophy? That's real. You got to work on that too. Linda said, I just had to travel in a car for 1,500 miles over 3 days. I had such pain and pressure on the second day I had to fly home. My urogynecologist said sitting doesn't affect IC. I was shocked. Yeah, it does. Sitting absolutely is devastating, and traveling is devastating to IC. We have in the earliest epidemiological study published back in the late 1980s, it showed that 50% of IC patients had pain when driving. Of course, now we know why. We know that that's being caused by tight pelvic floor muscles. So if you have pelvic floor dysfunction, you absolutely are going to have difficulty sitting and driving in a car. That's well-established data, and I can give you that early study if you want it. Janet says, I have dysfunctional slow transit colon 2 for decades. I'm halfway through pelvic physical therapy I developed 23 years ago after having my ovaries removed. I'm hoping physical therapy will make a positive difference in some way. It will, hon. Sandy said, I had my surgery on the 17th. My mass is stage 2 cancer. Oh, honey. Girl, you did it. 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 I'm so glad you're through the surgery. Now we know what's going on. Stage 2, treatable. Sending you lots of big giant hugs and good luck with your cancer treatment plans. Now remember, if they're going to put you through chemotherapy, that chemotherapy can irritate the bladder wall, but some types of chemotherapy can irritate the bladder wall. But there's a medication that you can use with chemotherapy that will eliminate that. It's called Mesnex. The irritation from chemotherapy is not the chemotherapy drug itself. It's after it's metabolized by the liver. It causes a very, very irritating substance, which then causes the damage to the bladder wall. But Mesnex transforms it and gets rid of it. So there are options there. Hello, Erin. David said, I haven't been on in a while. I hope everything's good. Hey, man, I got home health care. Life-changing having somebody here during the day so that I can actually do my work. Last week was my second week, and she's doing 4 days a week now. And she's making dinner. I'm just good. But listen, my parents are failing. There's very, very fragile. I mean, we're definitely in those last moments, I think. I don't think either one of them is going to make it through the end of the year, to be quite honest. So send lots of healing vibes my way. Jennifer says, spray the nest heavily at night. Yeah, no, I have a really good extermination service I use. I will use them for sure. Can I please put the email in here? Yes. I'll write it down here. icnetwork@mac.com. Diane says, I've been in Celexa for 25 years, so probably can't get off. Going to be hard to get off of it, hon. It can be done. If I remember correctly, I think it was like a 60 Minutes documentary or a Nova documentary. Somebody was talking about it. And the problem was from the manufacturer. The manufacturer, now I'm just giving, I'm not going to say what medication this is, but I'm just going to give you an example. Let's say the lowest dose they made was 50 milligrams. The lowest dose available for whatever medication that causes a discontinuation syndrome, 50 milligrams. And you can't cut the meds in half with these types of meds. So you have to go from 50 milligrams to 0. And that's when the discontinuation syndrome happens, because that's a very, very abrupt jump. Ideally, with other medications, they go from 50 to 40 to 30 to 20 to 10 and then off. You can do a very slow, gradual process. But for some of the meds like Celexa, they don't do that. And that's entirely on the manufacturer's shoulders. And I don't know why. It's baffling. Sherry says, Sherry, girl, finally had an MRI and it confirmed that my pudendal nerves are compressed. I just knew it. I do have more issues as well in my pelvic issue. We'll see the doctor soon for follow-up. I'm sorry, allergies are so bad today. My nose is just like running. And okay, Debbie says sitting is the worst. David says, I hope your parents are able to hang in there. Oh, honey, I'm so sorry. David lost his father over Christmas. I'm so sorry that happened to you. Life, right? Janet said, so glad you found help with your parents. I was on that journey. It's hard. Yeah. Mary says, what causes your urethral burning? Is it trigone referring there? But I don't know if the trigone can refer there, although it makes sense. Men who struggle with quote unquote IC pelvic pain often have pain referred to the tip of their penis that's coming from their bladder or their pelvic floor. So it kind of makes sense that maybe the trigone could be referring some pain. And what causes urethral burning? Hi, C. Morgan. We're going to look at estrogen atrophy. We're going to look at tight pelvic floor muscles. We're going to look at infection of the periurethral gland. We're going to look at chemical sensitivity from a new laundry detergent or soap. There are a bunch of things that can cause urethral burning. I'm not lying. If I put on a pair of underwear washed in sheer or Tide, within 5 minutes, I'll have urethral burning. There is some sort of chemical in Tide product that messes with my body down there. That's why I do seventh generation. I do seventh generation free and clear. I would never do, a mass market one. And even if I do that, I still rinse twice. And there are still moments where I don't rinse out enough. And I will let's say I'll put on a new pair of underwear on the next morning that I've just washed. And within 10 or 15 minutes, I'll have skin itching. And so what I've got to do is I've got to take that whole laundry basket and put it through another wash and rinse cycle with nothing at all, and then I can wear them. And maybe that's a sign of the small fiber polyneuropathy for me, because I am 100% sure that I have small fiber polyneuropathy. That's explaining this super, super sensitive skin, right? Which is crazy. Mary says, my urethra burns constantly, but you also have frequency all the time. So Mary, what did we learn then from the research presented? That frequency is caused by tight pelvic floor muscles, and that urethra burning could also be caused by tight pelvic floor muscles, along with estrogen atrophy. So have you had your muscles checked? And let me get this diagram again. So myofascial pelvic pain driven by muscles, the dominant symptoms of somebody with tight pelvic floor muscles are fluctuating pain below the waist, straining to void, urinary frequency, urinary urgency, and a sensation of incomplete emptying. The symptoms associated with the bladder wall are not what you think they should be. You would think frequency, urgency would be there, but they're not. The symptoms most associated with quote unquote IC/Hunter's lesions are pain as the bladder fills with urine that is relieved by urination. And if you have constant urethral and vaginal pain, but there's no association with bladder filling or emptying, and you have normal normal pelvic floor muscles, then that definitely means that there's something else happening in your pelvis which is causing these symptoms, like fibroid tumors pushing on your bladder, endometriosis, pelvic congestion syndrome. Okay, so Mary, so you had your muscles checked. So what did they find when they checked your muscles? And how long ago did you have your muscles checked? C. Morgan says, I just wanted to tell you that I'm going on 2 full years off of Elmeron and I'm doing great. Yeah, baby. My retinas are being washed, but they are staying steady and fine. I'm so glad. I am so glad that you're doing well. Your glasses, your 20/20 vision. My spot in my right eye, my spot is on my right eye and nowhere in my line of sight. Thank God. Keep up your good work. You're an earth angel. Thank you, hon. Yeah, and I'm really glad you're watching it. I have to say, I'm shocked. I was working with a patient last week who was still taking Elmeron, and she had eye problems. She had eye problems. She was diagnosed with pigmentary maculopathy, but she was still taking Elmeron. And the doctor was like, you need to get off of that now. And she's like, what do I do? Elmeron was helping her. And so that's where, again, we have over on the IC Network website, we have a kind of a resource center for the whole Elmeron eye issue and a transition guide. So what can you do if you're trying to get off of Elmeron? Well, remember what Elmeron does. It's a bladder coating. It's a chemical Band-Aid, right? And so then the fundamental flaw with Elmeron is something called its bioavailability. if you swallowed a Band-Aid, would you expect it to come out the other end of Band-Aid? And the answer is no, we have digestion. And the original company, Baker Norton, that helped develop it, they were the ones who did the published bioavailability study, which showed that 92 to 93% of Elmeron is destroyed by digestion. So only a small amount of it actually arrives in the bladder to do anything good. And so the bioavailability is quite poor. And we were excited when Alza Pharmaceuticals bought Elmeron, because Alza was known for drug delivery systems, and we thought they would apply their technology to improve the bioavailability of Elmeron. They didn't. So unfortunately, you have to take a lot of Elmeron over time to build up a coating in the bladder. And that's where the eye issues are a problem, because that Elmeron is distributed throughout the body by the bloodstream, and it does appear now to arrive on the retinas, where it causes some problems with the retina. And it can affect vision. And we have some patients who have very, very severe vision loss because of it. And that's why there are a multitude of lawsuits about this right now. A safer way of using Elmeron is not swallowing it, but putting it directly in the bladder. So if you do it that way, 100% of the medication arrives exactly where you need it, in the bladder. So some doctors have done Elmeron bladder installations, or a heparin lidocaine bladder installation. Elmeron heparin kind of do the same thing. The advantage of a topical as compared to an oral is all the medication is delivered to the bladder, but you are going to pee it out. A small amount might attach to the bladder wall, but you're still going to pee it out. What many patients have done over the years, because patients have been getting off of Elmeron for years because it just got so expensive, is they just transitioned over to one of the chondroitin-based supplements, because chondroitin is believed to have a similar bladder coating effect. And chondroitin is a building block of the bladder wall that is critical to the superficial integrity of the bladder wall. So patients have transitioned over to Cystomend, which is kind of the strongest chondroitin formula on the market, or Bladder Rest, or Bladder Builder. Those are kind of the preferred choices at this point in time. C. Morgan said, Elmeron helped in the beginning, but I honestly should have come off of it 10 years earlier than when I did. You know, Dr. Parsons appeared in a lecture on our website, and somebody asked him, will I have to be on Elmeron the rest of my life? And he said, no. What you have to figure out is it helping you? I mean, I worked with one lady who, she invested her entire life savings in buying Elmeron, little elderly lady. She was broke. And I asked her, did it help you? And she said, no. And I said, why did you keep taking it then? She said, because there wasn't anything else. And she was probably pelvic floor driven all the time anyway, right? Well, so what Dr. Parsons said is the way you figure out if it's helping you or not is you just reduce the dose. If you were taking 4 a day, he said, take 3 a day for a week. See if your symptoms change. If your symptoms get worse, then maybe it's helping. If your symptoms don't get worse, maybe it's not helping. So he said, go to 2 a day. Then you can go to 1 a day, and then you can stop it. Or you can swap in one of the other supplements. So, you know, hold on. Wendy said, I'm experiencing such a wear feeling on my urethra. It's almost as if there are tremors. Makes my pee spread out all over the place. Perhaps it's my pelvic floor. It is your pelvic floor. I notice that it happens at the same time when I can't pass gas and I have to strain so bad it's causing all sorts of feelings. It's definitely your pelvic floor. Definitely. And I'll show it to you. All right, so let us look at the pelvis. So here we go. Here is your pelvis, right? Hip bone to hip bone. This is the front, this is the back. Here's your pubic bone right here. Notice that these are mirrored, right? So the left side mirrors the right side, and these are, the pubic bone is connected right here. So let's look at it from the back side. We have a vertebrae. We have a triangular bone. These are vestigial vertebrae. This is called the sacrum. And here is your tailbone. And I want you to notice that your tailbone curves under. The other thing I want you to notice is everything that attaches to your tailbone. See all these things that attach? So if you're like me and you broke your tailbone and your tailbone's in a weird position, that is going to directly affect your pelvic floor muscles. Coccyx injuries are a common cause of all of this type pelvic floor. Okay, now let's look at the inside. There are 3 layers of pelvic floor muscles, so each knuckle kind of corresponds with a layer. These muscles are hard to access, so I am now sticking my finger in a vagina. And with my finger, I can get to the deepest muscles up here, which are piriformis muscles. See the tailbone right here? Yeah. See all those muscles that attach right there? If you ever struggle with rectal pain, I now realize that some of the pain that I had that I thought was from my rectum was actually from these muscles right here, right? But the shallowest muscles are right here. They're on the surface. And yes, my model is broken. It's supposed to look like a, what is that fish? Oh, I love that big fish with the long tail. The one that killed Steve Irwin. I don't remember the name of it right away. Oh, come on. It's on the tip of my tongue. Anyway, here you go. So let us look at these shallow muscles. These are your levator ani muscles. So we've got a hole for the urethra, a hole for the vagina, and a hole for the rectum. So look at these muscles right here. If these muscles are jacked up and super tight, it's going to affect your ability to have a bowel movement. If these muscles are messed up, it's going to affect your ability to have sex. If this muscle is jacked up, it's going to affect your ability to urinate. And the fact that you're noticing that there are times when your muscles are very tight and you can't pass gas and your urine tends to spray all over the place, that tells us that you have tight pelvic floor muscles. And that's when you want to whip out your wand and work on your pelvic floor muscles. So as an example, if you're working with a physical therapist, that physical therapist should teach you how to do this. But as an example, again, here is the pelvis. This is a wand that you can insert vaginally for a woman or rectally for a man. And look at this. See how easy it is now for me to reach these muscles and work on these muscles? When my muscles get jacked up, it takes me about 3 minutes of just massaging the muscle. I follow the length of the muscle, and I get that muscle to flatten and calm down. A healthy pelvic floor muscle feels like a raw chicken breast. A tight pelvic floor muscle feels like painful bacon or jerky, cooked bacon or jerky. Mary, they said nothing was found 4 months ago. I have plastic pain with filling plus all the rest, so I got it all. Honey, do you have Hunter's lesions then? Have they looked in your bladder and have they diagnosed you with Hunter's lesions? The number 1 cause of severe pain in the IC patient is untreated Hunter's lesions. And Hunter's lesions respond beautifully to treatment. But they have to be treated correctly. That's funny, see? And says, I think the potassium chloride ER med I was prescribed because of low potassium is making me flare. Is that possible? Yeah, it could be. But you're going to have to do it, hon. I mean, if you've got very low, I mean, my mother almost died from low potassium several years ago. She was inpatient for days. She went down to care for her elderly mother, and my grandmother was a verbal abuser. And my mom was down with her for about 3 weeks. And when she came home, she was deathly ill. And we just thought it was a cold, and it wasn't. And she almost died at home. They flat out told us if you'd waited another day, she would have died here. And it was all from a very low potassium. And that was back in the day where she was so afraid. She didn't want me to leave her. And so I slept in the hospital with her for 2 or 3 nights. And it was the old hospital that I was a candy striper at, so they let me. It's a small community hospital that doesn't exist anymore. So, girl, you got to take that potassium sensitivity very, very, very severely. It's important that that get treated. And so maybe what you could do is, how would I protect the bladder from potassium? Pre-leaf would not work. I don't know. Maybe I would ease it with a little bit of aloe path. Aloe is soothing to burns on your skin, and aloe can be soothing to the bladder, and your bladder is being tweaked by the potassium. So the aloe product that I really love is called Aloe Path because it's a combination of organic anthraquinone-free aloe with PEA that will calm nerves down. And so maybe Aloe Path might be an interesting thing to try. I think you should ask your doctor also for suggestions on what you can do. Mary said, I'd risk eye issues. To be honest, if you're in that much pain, you treat it in your eyeballs. It didn't help me, unfortunately. Maybe I needed a higher dose. Makes sense. Well, Mary, remember, Mary, we're all different. Okay, so Elmron's ideal for somebody with estrogen atrophy. Elmron's not going to touch a Hunter's lesion. And so we have to figure out what's causing your pain. We're long past the days of assuming that everybody needs Elmron. We're not there anymore. Now we know that up to 90% of IC patients have a neuromuscular problem going on as compared to a bladder wall issue going on. And there are a group of patients, who don't have urinary symptoms. They've been prescribed. They've been diagnosed with IC, and it turns out it's something like fibroid tumors or something like that. But something is triggering your pain. We need to figure out what is triggering your pain. Mary says, "What's the point of installations if you pee it out?" Well, because the way installations are created, they use a combination of ingredients that will help it pass through the bladder wall. And once it's passed through the bladder wall and it's into the tissue there, you're not going to pee it out. And so that's the art of creating an effective installation. Linda says, what about sulfenacin and mirabegron? My doctor says it takes a while to take effect, but causes dementia. Not mirabegron. Mirabegron is not an anticholinergic. So if we were to compare oxybutynin ditropan with mirabegron, the problem with the ditropan detrols is that they're anticholinergic meds that if you take every day for 3 years or longer, they're associated with an increased risk of cognitive decline and dementia. And so it's sad that the early meds that IC patients were recommended were all anticholinergics. Now that we have that data, there's a very strong effort to not give you anticholinergics. And that's where the mirabegron and the mirabetrix makes the most sense because they're not anticholinergic meds. So they are considered much safer. Jennifer, yes, a stingray. Thank you. Thank you, Denise. I was, again, my head was spinning yesterday and I had a wicked sinus headache just from allergies. And I was just struggling to find words yesterday, which was funny. Feel a little bit better today, but we're getting older. Nikki said, I did bladder installations, Elmeron, amitriptyline, hydro-distension. This is my 4th time doing pelvic floor. I've not had any relief with these treatments. I constantly have to urinate. Everything feels worse after urinating. Pain, feeling like I have to pee again minutes after I go. I can't sit as it makes the symptoms worse. I can't stand clothing to touch. Okay, so Nikki. All of that makes sense. You are not alone. You're like tens of thousands of other patients where you did the bladder installations, you did the Elmeron, and it didn't work. So you are an anatomical mystery to be solved. We have to try to understand what is driving your symptoms. And this is where phenotyping is really, really useful, because with the phenotype, we can now try to find the correct treatment for you since things aren't working so well. So let's use the Chris Payne system. Let's use the Chris Payne system. So concept number 1, Nikki, is do you have Hunner's lesions? Our first distinct patient group are Hunner's lesions. If you have Hunner's lesions, they're not going to respond to any of those treatments. Hunner's lesions require lesion-specific therapy. So, Nikki, has anybody looked in your bladder? And if they have looked in your bladder, what did they find? So, if they found lesions, the missing piece here is you have not done the correct treatments for lesions. But let's see. So, Nikki, go ahead. See if you can answer. Nikki says, I forgot to mention I do not burn when I urinate. I have an interstim and it didn't work. It causes more pain in the genital area. I've also done overactive blood meds and it doesn't work. Okay, so again, Nikki, have you had a hydro-distension or a cystoscopy, and has anybody looked inside your bladder? And if they have, what did they see? Do you have lesions or do you have a normal bladder? That's our first question trying to subtype you. Okay. Vonda here on YouTube says she's unable to take potassium chloride supplements because they cause awful flares. Yeah. Well, potassium is an ion like sodium. And so potassium chloride is a salt, just like sodium chloride is a salt. What's one of the earliest forms of torture but rubbing salt into an open wound? And so potassium certainly is going to irritate an injured bladder or a menopausal bladder. Okay, so Nikki has a normal bladder. So that's great news. It's great news. It means that there's nothing physically dysfunctional about your bladder wall. So all of those bladder treatments, pointless. You have a healthy bladder. Let's celebrate the fact that you have a healthy bladder. So the next thing that we're going to look at is estrogen atrophy. So let's go to IC subtype 2 bladder wall driven. Yes, you have a healthy bladder wall, but just out of curiosity, how old are you? Because one of the things that's going to make your bladder a bit more sensitive is dryness and estrogen atrophy. So that's something. Okay, so you're 43. And Mary, Nikki, how old were you when these symptoms first began? Is this new or have you had this for a long period of time? Is this new or has this been going on for years? It started when you were 39. Okay, Nikki, you get to be our case right now. Was there any event that you associate with the onset of your symptoms? Had you had a baby? Had you gone through chemotherapy? Were you under intense stress? Did anything happen back when you were 39 that you thought caused some of this? It's amazing. We should never ignore your intuition. Your intuition is important. Mary said, so we need a hydro-distension to diagnose, or a cystoscopy. Salt really bothers you. Well, Mary, I'm of the position that if you've been in pain for a long period of time, it's important to have somebody to look to see if there's anything going on there. I don't like guessing. If I'm in pain, believe me, I want somebody to look at it and tell me what's wrong with it. And our challenge here is that many patients are afraid to have cystoscopies, but a cystoscopy is just a quick looky-loo. It can be done in the doctor's office. They numb your urethra, stick a cystoscope in, take a look around, see if there's anything funky going on, like a bladder stone floating in there. A hydro-distension is done in the OR. It's where they stretch your bladder with a little bit of fluid, and it allows them to take a closer look at your bladder wall. And if they find a Hunter's lesion, they treat it. So the advantage of having a hydro-distension. So if, for example, you have a lot of blood in your urine, if you're in severe pain, then and the urologist is going, there's a pretty high chance that this patient could have a Hunter's lesion. That's going to justify doing a hydro-distension with cystoscopy. And the advantage of that is that they can then treat the lesions when they find it. Okay, Nikki said, I had doctors tell me I had a UTI and others and tell me I didn't. I had a bad allergic reaction to contrast dye. This put a lot of stress on me. Nikki, did you have any other bladder issues when you were in your teens or 20s? Mary says, can they not see lesions with cystoscopy? It's harder to see a lesion on a cystoscopy unless they do a specific type of equipment called narrowband imaging. Most urology offices in the United States are not equipped with narrowband imaging cystoscopes. And so they can see big things, but they might not see small things. It's the hydro-distension that will help them find the small things. Diane said, who is the best urologist in the Midwest? I live in Southwest Minnesota. Ken Peters at Beaumont Health in Royal Oak, Michigan. He is the top urologist in the Midwest, in my opinion. Cindy said, I've had IC for over 30 years. I've mainly urgency. I've taken amitriptyline for many years. I was diagnosed with retinal damage 3 years ago. I now take aloe vera and I've been doing okay with flares on and off. I've never been checked for pelvic floor dysfunction, but Elmeron definitely made me symptom free. Could it still be PFD? Yes, it could be. If you had a difficult childbirth and a UTI, yeah. Oh my God, allergies are so bad. I am sorry for scratching my nose. It's spring and it's windy. I don't like taking allergy meds. Okay, so Cindy, I'm so sorry to hear about the retinal damage. I really hope that you've looked into some of these lawsuits that are going on with that. We now know from research that was just presented on Friday that the symptom of urgency is primarily driven by pelvic floor muscles. And so it's you remember, girl, you and I were diagnosed back in the dark ages, because I was diagnosed 30 years ago too. And back then, everybody assumed that this was a bladder disease, and that's why they gave us amitriptyline and Elmeron. But of course, in the last 5 years, really the last 10 years, we now know that it's not just a bladder disease. And in fact, only 10% of IC patients have a bladder issue. The rest of us, these symptoms are being driven by nerves and muscles. And with the aloe vera is helping because it's soothing your bladder wall, but it's not fixing the underlying problem. I mean, ultimately, in the end, we have to focus on causation. We don't want to chase symptoms, which you've been doing for 30 years, which I did for a long time. We want to try to identify the underlying problem so that we fix the underlying problem so you don't have the symptoms in the first place. And you have not had the single most important examination. If you look at the guidelines that have been released in the last 11 years, pelvic floor examination is supposed to be done at the very first appointment. And in the new guidelines that were released last June, there are only 2 recommendations. Number 1, if you find tight pelvic floor muscles, get them to pelvic floor physical therapy immediately, because pelvic floor physical therapy is stunningly successful at reducing the symptoms that we commonly associate with IC, frequency, urgency. So you need a pelvic floor assessment, girl. You need, especially if you had a difficult childbirth. We don't want to be in the position of chasing symptoms. We want to try to identify underlying causation. And as long as you have tight muscles, you have what we call ischemia. You've never heard the term ischemia before. That's poor circulation. So if your bladder is supposed to get 24 units of blood a day and it's only getting 10 because your muscles are so tight, are you going to have a healthy bladder wall? No, you're not. You're not going to have a healthy bladder wall. That's the downside of long-term pelvic floor tension, is reduced circulation. So our therapeutic priority for the pelvic floor patient is to restore proper, good, healthy circulation. How do we do that? With pelvic floor physical therapy. All right, so let's get back to Nikki here for a moment. So Nikki is 43. Her symptoms started when she was 39. One doctor said she had a UTI. Others said she didn't. She did have a bad allergic reaction to a contrast diet and that she was under a lot of stress. Okay. So when we think about our subtypes, Nikki, so we're going to use the pain system for subtyping. IC subtype 1, Hunter's lesions. IC subtype 2, bladder wall driven. And in the bladder wall group, we're going to look at estrogen atrophy. If you were on a strong birth control, that would have reduced your estrogen levels to the point that your bladder wall could have started getting drier and more vulnerable. Or if you're an early perimenopausal woman, that, perimenopause is happening, you're in your 40s, it's going to happen. If it's not already happening, it's going to happen. And as your estrogen levels drop, your bladder gets more sensitive because your body needs estrogen to produce that nice, thick wetness, that mucus that normally protects your bladder. Your bladder is like your mouth. It's a hollow organ that's wet on the inside. And that moisture on the inside acts to protect tissue. So that moisture here, I have my thingy, where is it? The nice thick mucus that covers the bladder is integral to the health of the bladder. Unfortunately, it is estrogen dependent. So when you're young and have lots of estrogen, you have lots of mucus, you have a nice thick mucosal barrier. When you're older, you have much less estrogen, much less mucus. Your bladder wall's now compromised. So that 1 cup of coffee that you used to love in your 30s, all of a sudden in your 40s hurts. And it will feel like an infection, but it's not infection. It's just estrogen atrophy. And for those women who have been told they have incurable bladder diseases, they don't. It's just estrogen atrophy. That's all it is. So you want to have somebody look at your skin down there. And if you're showing signs of dryness, the correct therapy is a topical estrogen. But you have to talk to your doctor about that to learn about the pros and cons of estrogen therapy. The other thing we look for bladder wall driven symptoms is a chemical injury. So these are the patients whose symptoms begin after chemotherapy or using ketamine. The bladder, like any other part of the body, can be injured, and it's usually injured through some sort of toxic chemical exposure. So for those patients who drank a lot of diet soda or use a lot of NutraSweet or going through chemotherapy, their bladder walls can be injured. So let's make sure if you have a bladder wall injury, that's important. So if you're drinking coffee or soda all day, then that could easily be the underlying cause of why you're struggling. So that's subtype 2. And also in subtype 2, we do want to look for chronic infection, but it sounds like they've ruled out infection. But not just bacterial infection, we want to rule out fungal infection. So if you flare when you eat sugar, if you flare when you eat ice cream, then we want to look to make sure you don't have yeast or candida in your urinary tract. It happens. And that is research that was done by the U.S. National Institutes of Health that found that patients struggling with severe painful flares often had an overgrowth of fungus in their urine. So see if you can make a correlation between sugar and carbs and symptoms. If you do, you might have a fungal infection. Our third subtype is pelvic floor driven. So these are the patients whose symptoms began after some sort of trauma, like having a difficult childbirth, or if you fell and broke your tailbone, or if you were raped, victim of abuse, or if you were a gymnast or an ice skater or a dancer or a paratrooper or a football player, something that involves multiple falls, multiple traumas to the pelvic floor. The biggest risk factor for pelvic floor dysfunction is childhood athletics. So if you, again, were doing ice skating where you fell a lot, or gymnastics where you fell a lot, or if you were a young man playing football where you're hitting the pelvis, or if you were riding bicycles or riding horses, those all are going to affect the pelvic floor. But your first symptom is frequency urgency. You think, hey man, I'm having an infection. You call the doctor, hey, think I have an infection. Doctor gives you the antibiotics. They don't work. You go back to the doctor. Doctor goes, let's do chronic long-term antibiotics. You do those. They don't work. You go back to the doctor. The doctor says, okay, let's do some overactive bladder meds, ditropan, detrol. They don't work. You go back to the doctor, and the doctor gives you the, hey, I hate to break it to you. I think you've got this incurable bladder disease called interstitial cystitis. Here's the diet. Here's some Elmeron. Here's some amitriptyline. I'll see you in 6 months. And you legitimately want to get better. So you do everything. You do everything they tell you to do for 6 months, a year, 2 years, 5 years, 10 years, 20 years. Are you better? A lot of patients aren't. You still flare. Why? Well, for these patients, it's really not their bladder wall. It's their pelvic floor. And it's the pelvic floor physical therapy that actually heals them. I was in this group. I broke my tailbone in 7th grade. I was diagnosed with a urethral stricture a month later. I had like 100 urethral dilations from junior high through high school. My urethra was very narrow. The doctors go, oh yeah, let's just force it open with a metal sound. Not fun. Nobody ever asked, gee, why is it tight? Oh, duh, tight pelvic floor muscles. Bladder therapy's never worked for me. I have a healthy bladder. There's nothing physically wrong with my bladder. What's totally messed up are my pelvic floor muscles. And what makes me better and has gotten me symptom-free the vast majority of the time is not bladder treatments, it's pelvic floor treatments. And when I flare, I'm flaring because I've hurt my muscles in some way. That long car ride, that's going to cause a pelvic floor flare. If I've got to get in the bus airporter to go to San Francisco, which is a 90-minute ride, 2-hour ride for me, I will have pelvic floor spasms by the time I get to the airport, which is why I always travel with a skeletal muscle relaxant. So the big thing you got to remember is everything we learned about IC 30 years ago, thrown out. Now we understand diversity. Now we understand that 85 to 90% of IC patients are not bladder driven, they're muscle and nerve driven. IC subtype 4 is pudendal neuralgia. So these are the patients who have positional symptoms. They're fine when they stand, but when they sit down, it hurts. Or when they bend over, it hurts. That movement is triggering their symptoms. That means that you now have muscles so tight, they're compromising nerves. They're squeezing nerves. So if you have a pins and needles sensation, numbness, shooting pain down your leg like sciatica, that is absolutely a tight muscle squeezing the sciatic nerve. So anytime movement changes your symptoms, we're always looking at muscle and nerve. We're never looking at the bladder. And so our therapeutic priority for this group is to find out which nerve is the one that's being compressed, figure out where it's being compressed, maybe do some nerve blocks, obviously do some physical therapy and maybe some topicals as well. Because what you describe, honey, the reason why everything hurts is that you have allodynia now. That means that the nerves in the area have all become very, very sensitive. That's very common. If you get to the point where you can't wear underwear, you can't wear pants, that even the lightest touch triggers pain, that means that the nerves in the area have been sensitized by trauma, by injury. And I went through that for about a couple of months. My first year, you couldn't touch me anywhere below the waist without me gasping. I was in so much pain, and that's allodynia, and it does slowly go away. And last but not least, the subtype that is also incredibly compelling is a subtype of widespread pain. These patients have IC, IBS, vulvodynia, fibromyalgia, TMJ, migraines. There is a significant cluster of us, of IC patients, who have widespread pain. We are in our own distinct group. This is a central nervous system driven disorder. It's injury or trauma to the central nervous system. And therapeutically, what we're going to be doing is things that will calm the central nervous system down and restore proper nerve function. Nikki says, here, hold on a sec. Let me go back here. Mary says, atrophy seems like it's incurable. Honey, atrophy is not a disease. Atrophy just happens. It's a result of getting older. We got to be attentive to our skin and do the things that will help our skin get better, like topical estrogen. It's not a disease to be cured. It's just what happens as hormones change over time. Erica says, I love looking at the guidelines. I received pelvic floor physical therapy that helped. I definitely have pelvic floor dysfunction. I do have some relief. Stopping installations after weekly for over a year to see where I'm at. I've done a lot of pelvic therapy. Second week of no installations and still doing good. Good job, Erica. A lot of prayers after 5 surgeries that included a total a hysterectomy. Is that a TVH? Is total vaginal hysterectomy at 35? You can't give up. It's exhausting. Mary says, how do you get rid of the fungus in your bladder? Maybe with some antifungals and making sure you're not feeding the fungus with sugar. It involves reducing your sugar intake also. Linda says, how do they check for fungus? With a next generation DNA urine test. Anne says, is that the only reason to physical therapy I go and it was not anything of your mention? Physical therapy is now the cornerstone treatment, the single most important treatment for IC symptoms. All right, Nikki said, I haven't had any injuries prior to my symptoms. I had a child 19 years ago and pushed for 2.5 hours. I couldn't walk for a month. Well, okay, Nikki, seriously, you had a major skeletal muscle injury. You healed from that, never had any bladder issues. Okay, but the foundation is there. That wasn't a minor trauma, girl. That was a massive pelvic trauma that you experienced. And there's going to be a legacy to that trauma. The legacy to that trauma is probably trigger points in your muscles. You know, a trigger point is a little round knob, a painful muscle. You know, skeletal muscles, muscle fibers are long and lean, and they're horizontal fibers. And when they get tight, they slide like this. And when they release like this. So if I were to make a bicep of my pathetic bicep right now, that's a long, lean muscle. But then if I pop a bicep, right, I've now made these muscles do this. And then they release when I drop my arm. The legacy of injury, though, is muscles get stuck here. We call them latent trigger points. And that latent trigger point is a problem because, and I can show you a picture. Hold on. Let me show you a picture. This is going to be important for you to understand. Here you go. Okay. So this is a trigger point, right? So this muscle has been injured. And now it's stuck together there. The fibers are stuck together. And because it's bigger, look what it does to the surrounding structures, the blood vessel. See that? So now we have a blood vessel that has poor circulation because this is obstructing it. And you can see the same thing in this picture too. This is a healthy blood vessel. This is now a compromised blood vessel because of these trigger points. So while you might not feel symptoms from that latent trigger point, it persists. It persists. And then you suffer that maybe you fall and you get another trigger point. And maybe you have another baby and you get more trigger points. And then eventually, even something very, very minor can trigger those trigger points to become active, painful trigger points. Given that you had really a massive injury that you couldn't walk for a month, having a pelvic floor assessment is critical for you. And I'd bet you $100 your muscles are tight. And they've probably been tight since that happened. One of the symptoms of tight pelvic floor muscle, let me ask you this. When you go to urinate, can you start your stream right away? Or do you hesitate 5, 10, 15 seconds? Can you pee like a horse, or you're trickling, stopping and starting, stopping and starting? That means your muscles are involved. Erica says she needs a muscle relaxer, but can't receive them because I'm on anxiety meds. Even baclofen? Gotta talk with your doctor about your options here, or your local pharmacist. Wendy says, I have Hunter's ulcers, pelvic floor, nerve sensitization, IBS, migraines, fibro. What is my subtype? Hunter's lesions and widespread pain. That's your subtype. So Wendy, if I were to, let's see, gosh, there's so many different ways to go. Ultimately, it's the chicken or the egg, which comes first. And it's hard to know which came first for you. I mean, we could argue, for example, I give you a true story. We had a woman with severe Hunter's lesions who also had a prolapse. They went in to surgically repair her prolapse, and they made an incredible discovery that the front of her uterus was facing backwards and the back of her uterus was facing frontwards because a ligament was broken. A ligament was broken. So her uterus was free swinging on one ligament rather. So think about what that would have done to the nearby tissue and nerves. It's what we call a strangulation injury, a torsion. I mean, there's torsion there. So when they straightened everything out and got the uterus back in the correct position, her Hunter's lesions healed completely. And that helps support the position that Hunter's lesions are often caused by nerves that are very, very inflamed. So in her case, her cause was whatever broke that ligament. Could have been having a baby. So now we have a broken ligament. Her uterus is free swinging. Nerves are getting inflamed. And because she's in pain, muscles are getting tight. That's a possibility. Or maybe she suffered a catastrophic injury. Maybe she was in a car accident and she suffered both muscle, nerve, and ligament injuries in that car accident, which led to long-term symptoms, long-term pain, and etc. Wendy said, I had a very traumatic delivery and a big tear was created. Okay, so prior to childbirth, prior to that, did you have any urinary symptoms? Were you one of those people where you thought you just had bladder infections all the time, or did you have absolutely no symptoms until after that difficult delivery? Nikki says, I hesitate, but once the stream starts, it doesn't stop until I'm done. I feel swollen down there when I pee, and it feels weird. When I finish urinating, I feel a pain near the urethra. So, Nikki, may I introduce you to your levator ani muscle? Your levator ana muscles wrap around the urethra. Erica says, I have knots under my skin, all over my body, poor circulation in my lower extremities. The knots pulsate and then let go during physical therapy. I was told in my 20s I had fibro and needed extensive physical therapy. Now that I'm 52, my whole body hurts like crazy. Central nervous system wrecked. Everything you're talking about explains my body. How do I get treatment for this all over pain from knotted muscles? Physical therapy, massages, all of that. You know, hold on. I just want to make sure I get this right. So in the end, symptoms are being driven by organs, nerves, muscles, or bones, and blood supply. It's that simple. And so as we try to figure out what's driving your symptoms, we always have to go back and ask, okay, what is the health of our bones? What is the health of our muscles? What are the health of our nerves? What is the health of her blood supply, etc. So I want to say this the right way. I want to say this the right way. I never believed that I would get better in my 30s. I lived with very severe pain for a good 4 to 5 years. I was homebound. I had lost my job. I was living on credit cards. Thank God my parents were there for me, which is why I'm there for them now. And the turning point for me, well, there were like 3 turning points for me. Turning point number 1 was when I was at an emergency room and I had a doctor say to me, you will forever be a burden on your family. This is your life. Get used to it. You will always live with severe pain. That was a doctor at Kaiser Permanente in like 1994. And I went, wait a second. Wait a second here. I will prove you wrong, you son of a bitch. How dare you say this to me? That's a direct quote. And I went home and I started studying because I refused to accept that. I was not going to be a burden on my family. And that's what led to me becoming, starting the IC network and becoming a support group leader, right? Is education is power. And the more I learned, the more I saw very, very clearly that this was never my fault. I really thought it was all my fault. My self-esteem was non-existent. I didn't understand why I had all these pain conditions. It made no sense to me. Until I started studying. And I was like, oh, wait, yeah, trauma. Okay, that absolutely plays a role. So in my work studying IC back then, we first looked at the health of the bladder, diet, all that sort of stuff. I dove into diet. I used some of the meds. But then shortly thereafter, everybody started talking about tight muscles. And we had a physical therapist come to an IC conference who said, hey, treat the muscle. If you treat the muscle, the patients get better. And of course, all the doctors laughed and turned their back on her. Well, she was right. And even then, I didn't believe her for about 10 years. But I did go and have a pelvic floor assessment. And they went, yeah, your muscles are toast. We need to work on those. And even though I had that exam, I didn't do it. I didn't make the commitment to do it because I was still clinging to bladder disease, bladder disease, bladder disease. But then it was like bladder injury, bladder injury, bladder injury. And then finally it was like, oh, wait, had a hydro-distension, looked at my bladder, perfectly healthy bladder, nothing physically wrong with my bladder, but my muscles were toast. Once I started the right therapy, and once I committed to the right therapy, and once I made an investment in trying to treat my body better, that's when I got better. And I don't have bladder symptoms anymore, and I don't have IBS anymore, and I don't have vulvodynia anymore. The healthier my muscles are, the healthier my body is in general. And so you're going to have to make a commitment to learn some techniques to do at home. If you can, getting some physical therapy with an expert is critical because you'll never figure it out on your own. You have to go to a physical therapist at least once so that they can identify the muscles that are the problem. I want you to walk out of that first physical therapy appointment with the name of the muscle that's the problem so that when you get home, you can come back and you can refer to this book. You got to make a commitment to understand your body. This book is the single most important book you can buy for muscles and nerves. This is a master class. When you lay on that table with a physical therapist, I want you to know the name of the muscle, and I want you to visualize where they're touching. So when I talk about making a commitment to understanding your body, it's about making a commitment to learning about your body. This book is the place to start. It's $28. Buy it. They're $29. Worth it. And I will make you the same offer I make to everybody else. If this book doesn't work for you, I will buy it back from you. I have been saying that since this book came out. Nobody's ever sold it back to me. It is that good. It is a fabulous book filled with incredible case studies, right? So hopefully you've read this book, then you've gone to physical therapy, you've got the name of the muscle. Let's just say it's the levator muscle. Then the physical therapist can teach you some things to do at home with a wand, right? This is what I do. It works. There's a learning curve, but when I'm working with my muscles here, it takes me about 2 or 3 minutes to massage that muscle and get it to relax. It's a bit of a, I know it's weird, but it works. You can also go to YouTube and you can search for how do I, for levator ani. How can I relax tight levator ani muscles? And there are good physical therapists that will help you with that on YouTube. And then hopefully you can go back to physical therapy maybe in 6 months after you've made a commitment to do stuff and see how you're doing. I also think it's very important that you start getting massages. When you can, teach somebody in the family to do a massage. Go to, buy a book, learn how to do it on each other. Jennifer said, my physical therapist never talked about using a wand like that. Well, see, the thing is it's very important to be independent. If you're relying on a physical therapist to relax your muscles, you'll be forever dependent on them. And the problem is if you have a pelvic floor flare on a weekend, what are you going to do? Erica says, I used my wand and it caused more pain, so I haven't used it. That just means you didn't use it correctly. The thing about the pelvic floor, so, when I got my wand, I didn't know. Listen, I was laying on my bed trying to use it going, I have no freaking idea how to use this wand. None at all. None of it made sense. So I emailed my physical therapist and said, what do I do with a freaking wand? I do not understand what to do. My physical therapist said, move it in a J shape. Capital J, right? Capital J. I'm like, okay. So then I tried again, laying on my back on my bed, going J shape. Okay, makes no sense to me. Where is the freaking J? And it was this book that helped me find the J, right? So I'm going to show you the J right now. So again, we're looking inside at your pelvic floor muscles. All right. Here's the J. You've got two capital J's facing each other. J1, J2. It's a J shape. It is a J shape that begins at the tailbone. You've got, because the left and the right side mirror each other. So there you go. That's the J shape. Sometimes with physical therapy, they will have you go across the strands, across the muscle fibers. Other times they will ask you to follow the muscle fibers. And then if there's a trigger point in there, if there's a lump in there that's painful, a trigger point, you actually just kind of rub on a lump for a couple of seconds. And yes, it will be painful at first, but it should release. I mean, if you have a trigger point on your back, what do? You have somebody push on it. When you push on a trigger point, it usually causes it to release. So J shape. Now, for me, I will tell you that when I first started, my left side was jacked up tight. My right side was normal. That's like, okay, why? Well, now we know why. The reason why my left side was so tight was because of this joint right here. This joint right here, the SI joint, is moving when it shouldn't move. And so my muscles up here locked down tight to try to keep the joint together. But then I had a hysterectomy, and the hysterectomy jacked up my right side. So now, well, like last night, I didn't fall asleep till about 4 a.m. because my left butt cheek was vibrating and was in bad pain because of my SI joint. So what I should be doing is a little bit of physical therapy up here to try to get these muscles to relax. But sometimes my left side's really good and it's my right side that's messed up. You just have to, over time, you come to learn what good healthy muscle is and what tight muscle is. To me, a good healthy muscle is like a raw chicken breast. It's soft, it's pliant, and it doesn't hurt. A tight muscle is stiffer and it feels like beef jerky, and it's exquisitely painful. And so if I find an area that's very, very painful, then that's where I'm going to be doing my work. And again, it just takes a couple of minutes to try to get that muscle to relax. And it will relax. Another important thing to ask your physical therapist when you're working with a physical therapist is, are my muscles progressively getting normal, or are they always going back into tension? Because if they're always going back into tension, my left side was always going back into tension. Why? Because that's when we have to look beyond the muscles to the bones. Do we have a funky hip? Do we have a funky SI joint? Do we have a tailbone that's broken and pushed to the side? Do we have a bad knee? If you're limping, that's going to affect your pelvic floor because all those forces are going to be directed directly up into your pelvic floor muscles. But what Dr. Weiss found more than anything else is that long-term pelvic floor dysfunction is often caused by how you walk. So I want you to look at this picture. Look at this picture. So here is a healthy foot. And you can see that the shin bone is at a right angle to the floor. It goes straight up. And then we have the femur, right? And you can see up here, your piriformis muscle. That is a healthy piriformis muscle. It's kind of fat up here, right? Now look what happens if you have an ankle that rolls in. If you have an ankle that rolls in, you've lost your verticality here. Now the shin bone is at an angle, which is going to create a bigger angle up here in the femur. And now look at what that does to the piriformis muscle on this side. That is stretched an inch or two longer than this side. That is going to cause long-term pelvic floor dysfunction. And so what Dr. Weiss found was that the last step of therapy for patients with long-term pelvic floor dysfunction is getting your feet to a podiatrist to work on how your feet hit the ground. Are you pigeon-toed? Are you duck? Pigeon-toed is like this, duck-footed is like this. Do you have ankles that roll in? Do you have ankles that roll out? Do you have Morton's toe, Morton's neuroma? We've got to fix how you're walking. We normalize how you're walking. Now we're going to normalize your pelvic floor. Erica says, I never emailed you about the book. Okay. So again, if you use a wand and it hurts, then you're not using it correctly, and talk to your physical therapist, because the single most effective way for you to treat these muscles is to focus on where it hurts. You just said that there's just a learning curve for you to figure out what good healthy muscle is versus tight muscle. Jennifer says she's going to send her physical therapist a message. Good. Wendy said, I have the wand, but it's taken so much time for me to learn. When I've used it on Christmas Eve, my muscles got so tight, the wand got stuck. Okay, I'm terrified to use it again. Well, you can start shallow. You know, that's very, very common. Instead of going all the way in, start very shallow here. Work with the muscles right around your vaginal opening first. Just get in there and just be very, very gentle. It's about reteaching your muscles what normal muscle position is. Don't go for it. You know, you got to, I mean, I wouldn't just shove it in there and go for it. That's not a good thing. I'm not saying you did that, hon. And really, normally your physical therapist is the one who can kind of guide you through that process a little bit. Erica said, I did a sweep and my scar was killing me the next day. I know about trigger points. My hips are uneven. There you go. I will try again. I also have a TENS unit. I do exercise when my sciatica flares up. So if you have sciatica, you have tight pelvic floor muscles on that side. Depression. I lost my son 2 years. I'm so sorry, honey. I'm so sorry. Are you wearing good shoes? Have you worked with a podiatrist? I mean, given the fact that your hips are uneven, maybe using a little bit of like I use a extra foot pad in my right shoe, because I've got one leg that's about 1/4 to 1/3 of an inch longer than the other, and just to try to keep my hips as level as possible. And it's made a difference for me. Jennifer said, the involuntary movement disorder that I have causes my right ankle and foot to move in circles since 2013. Interesting. Was that an injury? Like I have essential tremor, so you can see it. You can see it in me during many of these videos, because what happens is if my neck gets really tight, my neck does this. So if you see me doing weird head movements like that, that's my tremor. Erica said, I had a neuroma removed on one foot, have one in the other foot. I have studied and learned a lot. I've learned from you. This is so hard. Do you have this book, honey? Have you read the chapter on the feet in this book? You need this book. If you don't have it, you need to get it. It's from the ICNet. You can get it from the IC Network. We get a special deal from the author, Jerome Weiss. So it's $6 cheaper on our website than it is on Amazon. Best book ever written. I mean, listen, my book, IC 101, is awesome. But for those of us who have nerve issues, muscle and nerve issues, this is the book to get. By far. So you say you've gone through 3 podiatrists trying to get all my, that's the problem is we don't have a lot of pelvic pain specialists in the country. If you're back in Pennsylvania, there's Dr. Robert Eckenberg, who's very good. You got Robert Molden, who runs a pelvic pain center in New York. But the pelvic pain doctors are fairly few and far between. That's why you've got to be super educated and do your research. You need to direct your care. You're the boss. They're not the boss. You're the boss. But the only way you can be the boss and make good decisions is if you know your stuff. right? You got to know your stuff. You're Maryland. Okay. So another, there's a website called pelvicrehab.com. Pelvicrehab.com. And so you guys, I'm simulcasting right now. I've got Facebook here and I got YouTube over here. On Facebook, I'm going to share my screen. So hold on a sec. On YouTube, you guys aren't going to see this, but I'm going to describe what I'm doing. So hold on a sec. All right. Desktop with face. Yes, there's my screen. And there's my Facebook page where I'm doing this with you guys. All right. So let me get rid of that. And we're going to close that. And we're going to go. I'm going to open up a new window. Oh, there you go. And we're going to go to pelvicrehab.com. Pelvicrehab.com. Okay, this is the master database to find physical therapists who are certified in pelvic floor physical therapy. It is a specialty now. So let's just put in Maryland. And it immediately comes up. So if we look at in the Baltimore area, let's just look at the Baltimore area. We have a lot of physical therapists. Anybody with the gray tag has an interest in working with pelvic floor, but it's the ones in the yellow tags that are completely certified in pelvic floor work. So for example, in Northern Baltimore, it's Kristen Joyce, and she is with Indigo Physical Therapy or Indigo Physiotherapy. So for anybody who's looking for a pelvic floor physical therapist, come to pelvicrehab.com, put in your zip code, and go for it. So I'm going to let's see. So I'm going to put in my zip code here in California. And the pickings are much slimmer for me, much, much slimmer. The nearest certified physical therapist I've got is over in Napa or down in Mill Valley. Who's that down in Mill Valley? Well, Lisa Iacobelli, who I actually know. But, you know, I got options here. I got some options. If you ever go to a physical therapist and they tell you to do a Kegel, it's not going to work. Here we go, Healdsburg. Anina, that's where she's who I should go to now. And I probably will. I need to go back. I can definitely, like somebody said earlier, I noticed when I had to get up twice last night to help my mom go to the bathroom. And when I was squatting over the toilet, her handicapped toilet, which I don't like to sit on, so I was like squatting over it, I could tell my urine wasn't going straight down. It was kind of coming forward, which tells me that my levator ana muscles behind my urethra are really tight. And I should go do a check-in with her and get a new set of, you know what, I'm just going to do it. This is what I'm going to do. Number one, what I need to do. I need to go have a fresh pelvic floor assessment, see where I am, but I also really desperately need to go have a neck massage for my TMJ. I'm going to set appointments. I'm just going to do it. I'm just going to do it. I got to do it. I know I need to do it. Sometimes it's so hard to care for yourself, right? It's just hard. Life is busy. Diane said, my bladder pain is better since having a hydro-distension with ablation 3 weeks ago, but now having knee pain. So I'm wondering if I just didn't notice the knee pain before because of the more intense bladder pain. I'm going to go get my knees checked with x-rays. Yeah, that's a good idea. Linda said, what can I do before or after back surgery to help prevent a flare? I can't even ride home without severe pain and need to urinate every 15 minutes. Well, hun, I have a couple of suggestions for you. Um, is it major back surgery or is it like a minor surgery? Like, are they doing like my fantasy is to have my spine straightened because I have scoliosis, right? But that's big time surgery. That's many, many hours in the OR. So the longer or the bigger the surgery, the stronger the anesthesia that they have to use. And of course, the challenge is that it turns off your ability to urinate. And so it might take a 12 to 18 hours for those nerves to wake up again so that you can urinate again. And so having a catheter, if you're spending the night in the hospital for that first night, would not be unreasonable, so that you're not forced to move and try to go to the bathroom freshly after having surgery. Um, Following the diet is going to be important. Relaxing is going to be important. Mind body medicine is going to be important. Maybe trying some PEA, palmitoyl ethanolamide. We've got research with surgical pain with that that's shown that has been helpful in calming nerves down after surgery. What's the health of your muscles, Linda? Why are you having the back surgery? I'm sorry, Vonda. I wasn't meaning to ignore you, girl. Vonda said, do I know of any electrolyte drinks or mix that doesn't contain potassium? No, that's the point of an electrolyte. They're pretty much always going to have potassium in them. The same goes for a prep for colonoscopy. It's very, very tricky. I will tell you that the colonoscopy preps that most IC patients use very successfully is a Miralax protocol with water or Gatorade. So with the Miralax protocol, what you do is they give you like 4 biscotal tablets, Dulcolax, which you take like around 5 o'clock the day before. Let's just say you're going to have a colonoscopy at noon. So you start your colon prep like around 5 o'clock the day before. And of course, you haven't eaten heavy foods for a couple of days just to make it super easy. So 5 o'clock, they normally have you take four biscotals. Takes about 90 minutes to start things moving along. And then the Miralax, what you do is you dissolve a bottle of Miralax either in 2 bottles of Gatorade or in 2 bottles of water. And you drink those down. And by midnight, you will be empty. Not irritating to the bladder at all, especially if you do the Miralax and water. I did Gatorade. My suggestion would be 2 different flavors of Gatorade. You can do clear, you can do green, you can do blue. You cannot do red or orange. But if you have Hunter's lesions, I wouldn't do Gatorade. I would just do water, and I wouldn't expect that to irritate your bladder at all. Anne says a vaccine would be helpful for UTI. Absolutely, and it's moving on. MV140. Research is looking fantastic. Okay. Erica says she has a great physical therapy. She specializes in pelvic floor. Insurance tapped out after 3 months. She said it's a game of insurance. I'm waiting for the insurance to start again. In the meantime, Erica, she should be giving you home things that you can do. What can you do to work with those muscles? There might be physical stretches you can do, but also internal work that you can do. Erica says, what types of things should I say when requesting a massage therapist? I know I can't do deep tissue. What I do, I personally like deep tissue myself. I'd say the more you press on it, the better it releases. So, but I have done a lot of massages over the years, although that all stopped with COVID. Ultimately, it comes to the training and the style of physical therapy that the physical therapist is going to use. I don't like the physical therapy that just pushes. I like the physical therapy that rubs. Man, I want this going along the muscles of my back. I want a nice, firm, long movement on my muscles. I don't like the little pokey here and there. And if you don't like the first one, you can always try a second one. It is just, let me just say this. There are some physical therapists, and somebody just called me about this like in the last 2 weeks, but it might have been a chiropractor who will push really hard right in on the inside of your hip bones. Like they're trying to get in there and move your bladder around. That's not recommended. Not recommended at all. In fact, it took 2 years of regular muscle work before I let anybody even try to do that. And that's how they can get to some of the pelvic floor muscles from the top. So just, for people, for physical therapists who are pushing really hard on your belly, or chiropractors, just remember you're the boss. You pay them. You can tell them to stop. Say that you don't want that. They need to go slow. Jennifer said her involuntary movements began back in 2006 out of the blue, but the first neurologist who I saw, he checked the PDR and he noticed that each one of the 3 meds that I had been taking all at the prior year all had very rare side effects, causing involuntary movements, Reglan. Oh, interesting. Wow, girl. Reglan is a medication for gastroparesis that's known for causing involuntary tremors. And I was on it for about a month before my tongue started vibrating. And I was having trouble talking. And I called the doctor, my regular doctor, and said, I'm having trouble talking. My tongue is moving. And he goes, oh, that's just your essential tremor. And his answer was, drink, have a drink before you go to bed, right? But then like 2 days later, I talked to the gastroenterologist who prescribed the Reglan. He goes, oh my God, stop it immediately. That's from the Reglan. It's notorious for causing involuntary tremors. And then he said, it chilled me to the bone. He said, let's hope it goes away. It might be permanent. And thank God it went away. Otherwise I couldn't do this job because I could barely talk when it was happening. Erica says she has fibro and was told no deep tissue. Sure. Jennifer, of course you can call. Absolutely. You're welcome to call me anytime, except just know that I'm more available in the afternoons and in the mornings. And I'm in California, so your afternoon is still my morning. So later in the day, it's always better for me. I do first come, first serve, and then I have a list of people I call. And I'm known for calling late. Because if you're back east and it's 5 o'clock here, I know it's 8 o'clock there, I will call you at 8 o'clock because I'm still working. I usually work until 6, maybe 7, sometimes longer. Mary said, such good info today. Thanks for sharing your personal pelvic floor story. You're welcome. We're all in this together, right? Nobody should do this alone. This is hard work. You have never worked as hard as you're working right now. You're working your butt off trying to cope with this very severe pelvic pain. And I want you to applaud yourself, and I want you to be proud of what you've done. I want you to hold your head up high. No shame, no blame. You've done nothing wrong. You're doing everything you can to get better. You just have to understand that a lot of the things that we thought were IC have thrown out now. Now we know that's simply not true. Now we know that the vast majority of IC patients have a neuromuscular disorder rather than a bladder disorder. Yes, you have bladder symptoms, frequency, urgency, but believe it or not, that's going to be caused by tight muscles. That's muscles messing up. So that pelvic floor physical therapy is the single most important thing for you to do. Oh, wow. Wow. Did the basketball game just ended? Are you kidding me? Hold on. Wow, the Warriors won today by 20 points? Dang. Wow. 120 to 100. I thought the game was tonight. That's exciting for those of us who live out in California. I love my state. I love California. I love my state. I feel safe here. I feel respected here. I have access to healthcare here. Yeah, it's more expensive to live in. But you couldn't pay me to move out of California right now with this political climate. This is exactly where I want to be. All right, guys. Well, listen, we've been going for, let's see, 2 hours, 2.5 hours so far. Any other questions? Are there any other questions that I can help you with? So if you didn't hear about the early research, we have the big IC conference. I mean, a big AUA conference with all the new IC research, and it's very exciting. I went through it at the beginning part of this meeting, so you can actually watch the recording and go through it again. I'm going to be featuring it extensively in our magazine, and I will probably do some videos on it. Jennifer said, did I grow up in California? Yes, I was born in Santa Barbara. Born in Santa Barbara, California. My dad worked for the state. And so I lived in Santa Barbara. Then when I was a kid, we lived in Bakersfield. And then we moved up to Northern California. And that's where I've been ever since. And every place I've ever moved, I've come back. I've lived in Connecticut. I've lived up north. Ariella, on Facebook, the stars, you have to buy them. And they're like a penny a star, something like that, or 10 cents a star. I'm not sure, to be quite honest. Usually at the very top, there's a thing, I put a message in there saying if you want to support our stream, stars, and there's a link, and you use that link. But another way you can support us if you can't give us stars is just come on over to our website, icnetwork.org, and sign up for our free newsletter. It's free, and my gift to you is a 40-page flare management guide, which gives you hour-by-hour rescue plans for your flares. And I never abused my email list. I only send out newsletters and clinical trial announcements. We've done 3 or 4 clinical trial announcements in the last 2 months because all the IC clinical trials are kicking off again now that COVID has waned. And so there's a lot of really good research happening. So you want to hear, including one clinical trial that literally is paying patients $20,000 to participate. So if you want to learn about these clinical trial opportunities for new IC research, go over to our website and sign up for our mailing list, and that's how you'll find out about it. Erica says, you have Go Lightly. Should I request something different? It's really rare that IC patients flare with their colonoscopy preps. But if you have Hunter's ulcers, I would be doing the Miralax protocol instead. Because you can do the Miralax protocol with water and there won't be any risk of it irritating your bladder at all. Go Lightly can have some citric acid in it with some lemon flavoring and stuff like that. Try to get non-citrus flavors if you can. Erica says, I'm filing for disability for the 3rd time. Other 2 times were over 10 years ago. Too many diagnoses to list. Guidelines state if IC exacerbates other condition, you can get approved. That's true. It's all about the totality of your condition along with your doctor's letters. Linda said, previously had a discectomy twice on one side, which I need to have. Now need surgery on the other side that will be more involved with screws, which concerns me. You have herniated disc. Girl, I have got 3 herniated discs right now myself. I'm sorry to hear that, hon. I'm sorry to hear that. I ruptured mine during a fire evacuation 2 years ago, and it's amazing what you do when a fire is roaring towards you. You know, you will do anything you need to do to save your family, which is what I did, and I ruptured 3 discs pretty significantly. I get a vibration down the back of both of my legs, which collects in my heels and in the arch of my foot, and that's from my S1. Diane, you're welcome. Diane said, thank you so much for all you do. Take care of yourself so you can help take care of us. Thank you, honey. You're right. Ariella says, I have a Hunter's ulcer and I think pelvic floor, it's possible I have both. Yeah, absolutely. If you have painful Hunter's lesions, your muscles will absolutely get tight. That's a response to pain. That's called the guarding reflex. So what we have to do is treat the lesion correctly. And when you treat the lesion correctly, the pain should go away. The pain goes away in 85 to 90% of patients. Then your muscles will release. But we also have to, it's also important to try to figure out what's causing the lesion in the first place. Erica says, is participating in the studies a bad thing? I've seen a lot of them, thought about it, but scared of the complications. Well, listen, hon, every IC treatment out there has gone through clinical trials. That's required by US law, by the FDA. They have to prove that it's safe and effective. So every treatment goes through stage 1, stage 2, and then stage 3. Stage 1 study or phase 1 studies are studies that are trying to determine safety and dosage. Phase 2 studies now apply that information to a larger group of patients to validate it. And stage 3 is the bigger study that leads to the FDA approval. And so right now we have phase 1, phase 2, and phase 3 studies going on. And the thing about the phase 1 study, I mean, it's really rare, to be quite honest, that I'm ever asked if I will help promote a phase 1 study, which I did. Understand, though, it's not like they're going in blind. They have already done a lot of research. They've already done a lot of animal studies. They already have some baseline safety data. They have mechanism of action. They know what they're studying. And they have convincing evidence which compels them to move forward. One of the studies, for example, that we're working with, and I can't say more because I have non-disclosure agreements, but they presented their early data at AUA on Friday, and all the doctors were very impressed. So, studies don't scare me. I think it's important that you just ask lots of good information and ask them what they think the pros versus the cons are. I tell the story on our website in our clinical trial center. Meredith was a writer for the Washington Post. She had IC, and she participated in a clinical trial, and we have her article that talks about all the things that she thought of. So that's something you can read on the IC Network website. Hi, Renee. And Renee has an S1 injury too. Thank you, Diane, for the 50 stars. Much appreciated. Let me see. So hold on a sec. Let me go over to the conference website here for a moment, and let me log in. Hold on. All right. Let me log in and oh, you know, like I'm an Uber geek, right? And I love looking at the research. Do you guys remember monkeypox? So monkeypox happened about a year ago, and it is a virus that causes pox, like circular um, pox, you know, throughout the body. It can happen anywhere. And it seemed to be more dominant in gay men, but it was also found in straight men. Anyway, they had a whole session dedicated to monkeypox. And I was looking at the pictures, and some of the pox was like these round infections throughout the body were like a centimeter big, concave, bright red circles filled with infectious virus, obviously very, very contagious. The worst one, though, was like this big, and they had a picture of it, and it was like, damn. So they had a picture of the active pox, and then they had a picture 6 weeks later of the healed pox, and it healed. But woo, that was shocking. Let's see if I can find anything else. Etiology of recurrent cystitis. Ooh. What is this? Okay, you know what? Let's just cruise through this and see. Oh, look at that. Whoa. Okay. Let's just go through some of these here. Okay, so here's a course. It was yesterday. Etiology of recurring cystitis based on the vaginal microbiome, thinking beyond the bladder. So can recurring cystitis be the result of changes in normal bacteria in the body? We aim to determine the etiology of recurrent cystitis from the vaginal microbiome and to evaluate the importance of the presence of lactobacillus in the vagina. Vaginal samples were obtained from postmenopausal women classified into 4 groups: healthy, patients with uncomplicated cystitis, patients with recurrent cystitis, and patients with recurrent cystitis prevented by the administration of lactobacillus suppositories. A total of 120 vaginal samples from 139 women were studied. The vaginal microbiome of recurrent cystitis is essentially different from that of uncomplicated cystitis. Moreover, the lack of lactobacillus in postmenopausal vaginal microbiome is associated with the development of recurring cystitis. Thus, the vaginal administration of lactobacillus prevents recurring cystitis by improving the biome. Okay, that was not in the IC session. That is so cool. Okay, that was done at Beaumont, Ken Peters. Okay, let's see if we can find anything else. Hold on. Okay, that's okay. What is it? No. Okay, here's a new treatment. This was presented today. What is this? And what session is this in? This is in the session on bladder and urethra, anatomy, physiology, and pharmacology. ATP2C1 is a candidate for interstitial cystitis bladder pain syndrome. Okay, what the hell is this? Let's see. Hold on. Interstitial cystitis is a chronic pain disorder causing symptoms of urinary frequency, urgency, and bladder discomfort. Whoa. We performed genetic analyses of whole exome sequencing on a total of 109 individuals with IC, 93 women, 16 men. Each individual had a cystoscopy, physical exam, urinalysis, and completed questionnaires. and their urologist confirmed the IC diagnosis. Data was analyzed. Okay. They're looking at genes. One family had a previously reported 6.5 variant consistent with what? What? One family previously reported 6.5 variant consistent with brachio-otoretinal syndrome 2, a likely pathogenic heterozygous variant in ATP2A2 was identified in 2 probands, indicating possible Darrier-White disease. Whoa. Okay. Okay. Whoa. Hold on. Hold your horses. So this is a genetic study looking for unusual rare diseases that could manifest as interstitial cystitis. Okay, so the first one they found is brachio-otorenal syndrome, which is associated with the ears and kidney malformations. What? Okay, that's interesting. Remember, guys, we are all a genetic soup, right? I mean, Don, I'll get it for you. Okay, now the second one, Darrier-White disease. What the hell is Darrier-White disease? See what that is. Keratosis follicularis, also known as Darrier disease, is an autosomal dominantly inherited dermatosis characterized by greasy hyperkeratotic papules in the seborrheic regions, nail abnormalities, and mucous membrane changes. Well, the bladder has mucous membranes. And Haley disease? Indicative. Okay, what the hell is Haley disease? What? Haley. Remember, guys, we are an anatomic mystery to be solved. Nobody's saying everybody has any one of these things. They're just looking at genetics. So what the hell is Haley disease? Haley disease, also known as benign chronic pemphigus, is a rare skin condition that usually appears in early adulthood. The disorder is characterized by red, raw, blistered areas of the skin that occur most often in skin folds such as the groin, armpits, neck, or under the breast. I have a skin disease. I have, what's it called? I have a weird skin disease. If my skin gets hot, I get red bumps in it. Okay. Well, let's just go to the conclusion. Our data suggests that some individuals with IC may have an unrecognized Mendelian syndromes. They've identified some genes. Impairment of ATP2 leads to a dysfunction in the Golgi-associated human secretory pathway that results in recurrent blisters and erosions in intertriginous sites. Studies show that genetically screening individuals with IC may be useful in diagnosing and treating this painful disorder due to its heterogeneous nature. Okay. And that was an NIH study. Fascinating. Okay, guys, obviously, I'm reading these blind. I'm going to have to do a lot more reading on that. Let's see what else we can find. An infection phenotype in IC bladder pain syndrome. Wow, why didn't they put this in the IC session? That's wackadoo. Okay, this is okay. A subset of IC patients experience recurring UTI with symptom flares. This is the MB140. That's the vaccine for UTI. Okay. See if there's anything else. The real life practice of intravesical Botox. Long-term outcomes. Hey. This is interesting, and this is tomorrow. Long-term outcomes of COVID-19 associated cystitis. Ooh, let's look at this. Because we've been talking about COVID cystitis for a long time, right? COVID-19 cystitis is a newly described condition associated with the new onset or exacerbations of baseline urinary symptoms that may be present as a manifestation of long COVID. Little is known on the management and long-term outcomes for patients suspected of having COVID cystitis. In this study, we aim to assess their long-term efficacy of conservative overactive bladder on their symptoms. A total of 350 patients with COVID-associated cystitis were identified, of which 250 had new onset and 100 had worsening overactive bladder symptoms after COVID hospitalization. Follow-up at 21 to 28 months reveals significant decreases in overactive bladder and quality of life. Ooh, that's bad. Overall, 87% of patients improved with standard therapies with a decrease in overactive bladder and quality of life score. Of the 250 patients with new onset symptoms, 220 had improvement in their symptoms, whereas those with existing overactive bladder, only 60 improved. In the latter, overactive bladder scores decreased. So this is a first long-term follow-up of patients with COVID-associated cystitis. We found that after 21 to 28 months, only 13% of patients had persistent lower urinary tract symptoms. Patients with long COVID and COVID cystitis may be reassured that the symptoms resolve in the vast majority of cases and that supportive and reversible treatment should be recommended. Okay. Of course, where does that come from? One of my favorite research centers, Beaumont. Wow, that's cool. That's good. That's good. So we can assure some of these patients struggling. We have a lot of patients newly diagnosed with IC that actually have COVID-associated cystitis. What else do we have here? What is that? Phase 2 study for, hemorrhagic cystitis. No, that's not us. Hold on. Distinct phenotypes of bladder pain. Okay, we've got that. God, the research is so good. Oh, look at this. The role of microgen testing in patients with lower urinary tract issues. And negative standard. Oh, this is cool. Patients with acute lower urinary tract symptoms and negative standard urine culture are challenging to manage. Some may have identifiable organisms on next generation DNA testing. We sought to better understand the relationship between patients with negative cultures and a positive identifiable microbe. And 122 patients were reviewed, of which 116 had identifiable bacteria and 17 had identifiable fungus. Of these, 95 had negative urine cultures and identifiable microbes on next generation testing. And let's see. Most patients with lower urinary tract symptoms and negative standard urine culture have identifiable pathologic microbes on NGNS testing. The clinical utility testing is unclear, as symptomatic improvement with targeted antimicrobial treatment occurred in only half of these patients. Okay, well, guys, the research movement is hopping. This is good stuff. If you're a geek like I am, this is good stuff. The burden of bladder-resident bacteria in trigone biopsies. Okay, let's look at that. Antibiotic-resistant recurring urinary tract infection is common in postmenopausal women. Many elect to undergo electrofulguration on the areas of chronic cystitis when standard antibiotics have failed. Previously, tissue-resistant bacteria have been observed in the bladder walls of postmenopausal women with recurring UTI. We hypothesize that increased urothelial bacterial burden decreases the likelihood of complete recurring UTI. Hold on, let me just go to the results. In this pilot study, we observed that total bladder bacterial burden as quantified was associated with a 5.3 times increase in the risk of UTI relapse within 6 months in postmenopausal women following electrofulguration. Continue to note this between. Fascinating. All right, well, listen, I'll stop geeking out on you guys. Okay, what have I missed? What am I reading? I'm reading the abstracts that were presented at the American Urology Association conference on Friday. Diane says, my IC was worse after COVID. Yeah, that's what our research shows. Ariella says, how do you treat the ulcer diet? You just have to avoid the big foods, hon. We have a whole section on diet on the IC Network website. Just go to icnetwork.org. No coffees, no teas, no sodas, no multivitamins, no citrus, no tomatoes. You got to protect your bladder. Erica says, my jaw's on the floor. I had COVID when it first came out. Been getting installation. Yeah, COVID cystitis. These are abstracts. I'll give you a link. There you go. AUA2NE23.org. But you're probably not going to be able to read a lot. This is a conference for doctors and for researchers and people like me. But you can try. See what you see over there. Mary says the list seems endless if the bladder falls victim. Yeah, it does. It's amazing. I mean, it's really amazing. But again, I mean, the blessing here that we all have to celebrate is we're not condemning patients to decades of bladder treatments that are ineffective anymore. And for those of you who were diagnosed a long time ago, and you've been on Elmeron for years, and you've been on amitriptyline for years, it's very, very important now that you ask yourself, am I better or am I still struggling? If you still flare, then nothing has been fixed. And we have to try to repair whatever's damaged. Again, it's about cause versus effect. Your symptoms are the effect. We have to figure out underlying cause. And what the research shows, it was presented on Friday, is that the most common cause of urinary frequency urgency is not your bladder wall. It is your pelvic floor. So let me show these slides again. This didn't print out very well. So for the myofascial subtype, the symptoms are fluctuating pain below the waist, straining to void, urinary frequency, urinary urgency, and a sensation of incomplete emptying. That is associated with muscles. Bladder-specific symptoms, pain as the bladder fills with urine. Here, hold on. And bladder pain that is relieved after you empty your bladder. Those are the dominant symptoms for the bladder wall subtype. And there's also this other group of patients who have pelvic pain. They've been diagnosed with IC because they have constant urethral and or vaginal pain, but they have healthy bladders. And they're in the non-urologic pelvic pain subtype or the widespread subtype. And for these patients, if your pain does not get worse or better as you urinate, or if it's very, very steady, or it's dominantly urethral or dominantly vaginal, then we have to stop looking at the bladder entirely and look at what affects the urethra and the vagina. And so I know it's a little confusing. Just know that we're practicing precision medicine now. We have to figure out your phenotype to find the right treatment for your unique case. And I think this slide probably says it all, because who responds best to treatment? So for patients on amitriptyline and antidepressant, look, the pelvic floor patients have very little response. But the patients with bladder pain syndrome and the patients with pain outside of the bladder do okay with an antidepressant, because antidepressants kind of help to calm irritated nerves down. But the patients who respond the best to pelvic floor physical therapy are very clearly the patients with muscle problems, 90% of you, and that the bladder wall pain patients don't respond well to physical therapy. And for bladder installations, who responds well to bladder installations? Well, not the pelvic floor patient. The patients who respond well to bladder therapies are the bladder wall group. And last but not least, we have here bladder analgesics. Who does best to rescue installations or the pyridiums? Again, not the pelvic floor patients. So if you use a pyridium, and it does, this makes sense, because I can remember in my first year, they gave me pyridium and it did nothing for my pain. Nothing. Why? Well, that's yet another way of kind of helping to select underlying causation, because pyridium acts to numb the bladder wall. But if you are unresponsive to pyridium, if you're unresponsive to a bladder installation, then maybe your problem isn't the bladder in the first place. Maybe your problem is your pelvic floor or muscles. Angie says, does pre-leaf help, and how well? Pre-leaf is awesome because it helps to reduce the acid in the foods you're eating. So for patients with Hunner's lesions, patients with estrogen atrophy, where foods are really going to make a difference and potentially irritate your bladder wall, you can take 1 or 2 pre-leaf with your meal, and that will significantly reduce the acid levels. Or if, for example, you're scheduled for a colonoscopy and you have to do a colon cleanse that has a lot of citric acid in it, potentially you can take a pre-leaf with that, or maybe even a Tums with that, as long as it's not pink, that would help to alkalinize some of that effect by the time it reaches your bladder, potentially. But of course, you would have to ask your doctor for permission to do that, right? So pre-leaf is, as you can see, I mean, they've been a sponsor of the IC network for 25 years and counting. Love their product. My only hesitation with pre-leaf is you don't eat it like candy. Some people do. It is calcium glycerophosphate, and the calcium has to go somewhere. And if you are at risk of kidney stones, then they probably don't want you to do something like pre-leaf, right? The new thing, we have something new. I'm really not that prepared to talk about it as much yet, but ow. So this is a new a new product from Natural Approach Nutrition, and we're still working on content here, but this is endometrio, and this is designed to reduce some of the inflammation that's associated with endometriosis. Nobody's ever tried to do anything like that before. It was a project done behind the scenes of the company that makes Bladder Builder and Bladder Rest, and it's fascinating, absolutely fascinating. And so I will have a little bit more information on this as well in the coming week. But Natural Approach Nutrition continuing to kick it. Oh, I also have bad news. FAR Laboratories, the makers of Statistical, which was one of the very first supplements ever created, has declared bankruptcy. And I got notified of it by the bankruptcy court yesterday, and the creditor meeting is tomorrow at 11, so I will be doing that. Michelle says, I have a level 3 for prolapse from antispasmodic meds because of pushing to pee. Could you explain the surgery to repair this? My doctor made it sound horrific. Will it help my symptoms? So Michelle, number one, a big giant hug to you. I mean, seriously, big. I'm so sorry that you're going through this, but you're a tough cookie. And in the end, we want to try to repair underlying damage. So you have experienced the worst thing that can happen with straining. You have to remember that urination and defecation is about relaxation. That when you sit on the toilet, a muscle relaxes, the sphincter opens, and your bowel movements and your urination should just flow with no stress. But if your muscles are injured and or you have tight muscles, that doesn't happen. That you sit on the toilet and you wait and wait and wait for your muscles to relax. And sometimes it takes 30 seconds. I worked with one person who said it took her 10 minutes before she could urinate. Her muscles were so tight. You can be tempted to strain. And when you push tight muscles, so you're tightening muscles that are already tight and creating a tremendous amount of dysfunction in those muscles. And in the end, it can result in the development of little pockets. And so a diverticulum, for example, a urethral diverticulum is a little pocket that when you're straining hard and your skin's a little weak, it just pushes urine to the side into this pocket. And that can happen with straining. But in the end, muscles become so damaged that they basically kind of collapse. And then we are in a prolapse situation where these pelvic floor muscles, which normally hold things in place, are now weakened in this area. And so now the bits that are above these muscles start to fall through. That is called a prolapse. Now, if you catch a prolapse early enough, something as simple as a Kegel will strengthen those muscles and fix it. But if the prolapse has progressed beyond that point, there comes a point in time where really you might have an option to wear a pessary. A pessary is a solid structure that gets inserted. It can be a bunch of different shapes that is inserted up in the vagina, and it actually ends up holding everything in its proper place. Pessary, a lot of competitive athletes in their 20s, especially runners, have to wear pessaries because their extreme workouts have damaged and strained their muscles. Pessaries are icky at times. because you have to put them in and then you have to take them out. And some pessaries are left in for 6 weeks. Some are pessaries are just left in for a day or two. But in the end, it's a bit of it's an issue. Michelle, one of the ladies that I worked with for many, many years, and she's very elderly, and I actually think she's probably passed away. She developed they found her prolapse in her 60s. And she was scared of the surgery, so she didn't have the surgery done. And what happened is, as time went on, the prolapse got worse and worse and worse. And by the time she was in her 80s, she had, things hanging out of her body. And she was too old to have the surgery. So she ended up being fitted with pessaries, and it was a royal pain in the ass for her, literally. She regretted not having the surgery terribly. But once she was in her late 80s, early 90s, they simply would not do it. And I talked with her. By that time, she'd moved back east with a son. I talked with her many times over the phone. And her number one message was she greatly regretted not having it surgically repaired. She waited too long. So, she has an important lesson for you, Michelle. I mean, there comes a point in time when that prolapse has progressed so far that the best option is to tack it up. Now, in the old days, they used to use vaginal mesh. Of course, we've now learned that polypropylene vaginal mesh it can be quite damaging. And so the preference now with prolapse repair, if possible, is to use your own skin and to use your own structures. That way we don't have a foreign mesh in your body. So that's asking how they propose to repair it is important. Will they be using a mesh or will they be using your own body? The other thing about a prolapse that's important is that the skill of your surgeon is critical here, because in the end, however they do it, they have to rely on their fingers to determine if the muscles are at the correct tension. Because if they do it too loose, you're going to have more prolapse. If they do it too tight, it might be a little bit harder to urinate. Some people have had to have it so tight that 6 months later they go in surgically and release it a little bit because the surgeon just got it too tight. So I would want to know what the skill level of your surgeon is. How many have they done? I would ask them, what complications do they see, and have they had to go in and surgically repair the procedure that they did originally, and just get a feeling here of what their skill level is. I would want an older, much more experienced surgeon than a younger surgeon, to be quite honest. And that's what our IC guidelines say. Our IC guidelines say for any surgical procedures with IC, they want you to work with a very seasoned, skilled IC specialist who has multiple experience. The good news here, Michelle, is this surgery is done every day. There's a lot of history for it. The success rate can be very, very high. It can really help incontinence if you're struggling with incontinence and just discomfort from getting these bits right back in where they belong. I think it's fair to say, as they said for me, when I ruptured discs in my back, my spinal surgeon said, these are going to heal, but they'll never be as strong as they were originally. And I think that you might be able to make that correlation with muscles as well. The odds are, after you have this done, you're going to have post-op instructions are going to be very, very important. Lifting is going to be avoided probably for a year. And I think you need to be prepared to change the style of your life to make sure that you're not putting strain on your pelvic floor so that you don't do them again. It's kind of the same with hysterectomy. with hysterectomy, they don't want you lifting anything for at least 6 months because we don't want to rupture any, the thing with a lot of these surgeries, especially hysterectomy, is that hysterectomy stitches are 90-day stitches. They're stitches for 3 months. They don't dissolve in 2 weeks. And if you stretch the wrong way and lift the wrong way, you can rupture one of these stitches, as I did it 6 weeks after my hysterectomy, just by picking up a damn t-shirt off the floor. And so I would really, really, really be paying attention to the post-op instructions here. And just know that powerlifting is not going to be in your future. Maybe bike riding might not be in your future. We want to avoid anything that's going to put stress on those muscles. But if you do that, your life should be great. It's just injuries happen. These things happen. Not your fault. No shame, no blame. But one of the challenges that we have to face as we get older is that we're a little bit more vulnerable now. Things can be hurt a little bit more easily. And so, you're going to have to really guard and protect your pelvis from this point forward. But I truly wish you the luck. I wish you, I know that these surgeries are done daily, and I wish you absolutely the best in your surgery. And I think we learned from this other elderly woman that she waited too long and she really regretted it. Another thing that sometimes they can do that sounds a little bit extreme, if you're much, much older, is another way that they can deal with a prolapse is just by sewing shut your vagina, so that where they've sewn it shut, it just holds everything there. But if you're still having sex and you still want to have babies, that's obviously not going to be an option for you, right? But I wish you the luck. I wish you the best, Michelle. Come on, carry hope in your heart. You need to start doing some affirmations here. I can do all things through my faith, which strengthens me. I believe that my future is good. I believe that my medical care will put my life in a much better, a much better place. Let's start using some really good affirmations. Don't assume the worst. Let's assume the best. For all we know, this surgery is going to be perfect for you. It's going to get you exactly where you need to be with respect to healing your muscles, et cetera, et cetera. But full information, have a good talk with your doctor. One of the concerns that I had with my hysterectomy is that I had a laparoscopy the year that I was diagnosed with IC. It was September 1993. And they used a very, very strong anesthesia. So I was not able to naturally empty my bladder for like 10 hours. And in fact, they sent me, normally you're not sent home from the hospital until you can pee. I was sent home and I had not urinated. And my bladder got fuller and fuller and fuller, and I was wicked in pain. And finally, like 8 o'clock or 9 o'clock that night, I was able to release it. The anesthesia completely wore off. Well, 6 years ago when I had my hysterectomy, when you go in for surgery, normally, they come out and get you from your waiting room, you change clothes, they throw an IV in there just to chill you out, usually a little bit of hydroxyzine, just to calm any tension. And at least at my hospital, the anesthesiologist or the doctor coordinating anesthesiology for that day came in to have a talk. So he came up to my bed. I was just laying there, just kind of chilling. He goes, so Jill, do you have any questions for me? And I said, yes, I do. As a matter of fact, I want to be able to urinate after this procedure. My number one goal here, this best case scenario for me will be that I wake up in the OR, you bring me into recovery, and 20 minutes later, 30 minutes later, I will be able to empty my bladder. Because I have interstitial cystitis, and holding urine in my bladder hurt, right? That was, this was some time ago before we understood stuff. Anyway, he goes, you know what, Jill, not a problem. You know what we're going to do is we're going to use propofol for what you're having, which was a DNC. Propofol is perfectly appropriate. Propofol is the medication that Michael Jackson overdosed on because it was done incorrectly with too much. Okay, but the advantage of propofol is it's very mild. You fall asleep easily and you wake up easily, and it doesn't turn the nerves off with your bladder so much. Now, and so after my DNC, and they only use propofol, I literally was able to pee 20 minutes later. It was spectacular. I was ecstatic. And then 2 weeks later, when I went in for my hysterectomy because they thought they found evidence of cancer from the DNC, again, this is another guy came in and said, "All right, Jill, do you have any concerns?" I'm like, "Yes, I want to be able to pee afterwards." And I explained that I'd been sent home, unable to pee for 10 hours or whatever. And he goes, "Okay." And I said, "I really like propofol. Would you please use that?" And he goes, "Well, we can't just use propofol for a hysterectomy because it's bigger surgery, but we can do half and half." And I'm like, "Do it." I'm in for that. And by golly, what was amazing is I woke up in recovery. They're shaking you up. "Jill, come on, Jill, it's time to wake up." And you're going, "No, no, no, no. Come on, Jill, it's time to get up. Time to put your clothes on." You're like, "No, go away, go away, go away." And she went away for about 10 minutes and she came back up and she's like, "Come on, Jill, you got to get up. It's time to go home." Right? And you're all groggy and you're like, "Oh, okay, okay." And, she sits you up and I go, "I need to go to the bathroom." And she goes, "Perfect. We'll put your clothes on in the bathroom," right? And you're just like reeling, going, "What? I just had surgery. Leave me alone," right? So anyway, I shuffle off to the toilet, sit on the toilet, and by golly, I could pee. It was incredible. I was able to empty my bladder very shortly after surgery. The propofol worked. The surgeon was perfect. And the anesthesiologist was perfect. And then, of course, you're sitting on the toilet. I stand up. She literally throws my dress over my head, pulls it down. I wore this long cotton dress. And she's like, "All right, we're going to wheel you out. Your sister's coming in the car." I was home 90 minutes after waking up in the recovery room after having a hysterectomy. All right, crazy. So Michelle, that's the other thing that I would ask. Now, I don't know if that's appropriate for the surgery that you're going to have. It might be. And so I would ask about that. I would ask what anesthesia, just tell them that you want to be able to urinate afterwards. I don't know. I don't know if they're going to leave you with a catheter overnight. I don't know if you're going to be inpatient. I don't know any of that. But you can ask all those questions. You can ask all those questions. And it just depends on what they find, what they have to reconstruct, if they have to reconstruct anything, right? But I wish you the best of luck, girl. You got this. Linda says here, "I had a prolapse. It was very painful to move. The pain greatly improved when I had the surgery." There you go. So Linda here on Facebook, the surgery really helped her. Richard, Richard, I've never had anybody do this in a support group meeting. He's asking if he can. Wait. Richard, seriously, dude, are you trolling? Are you trolling my IT support group for girls? Looks like you are. Yeah. So, honey, you are suspended. Well, that's a first. That's a first, having somebody come into a support group meeting to meet girls. Well, now, ladies, I would encourage you not to respond. All right. Any other questions? Otherwise, I think we'll call it. It's almost 5. 4:45 here. Any other questions on IT? Otherwise, I'm going to spend this week going through all the new stuff. I'll be taking the course on IT, the 2-hour course. And next week, we're going to have another big intensive meeting with all the new stuff. Okay? So last call for questions. Last call for questions. I hope you feel good. I feel pretty good right now. I'm going to go take a walk. Listen to my book on tape. Anybody else? Last call for questions. All right. All right, you guys, be well. Remember your homework. For 15 minutes a day, I need you to do something for your spirit. Whether it is getting outside in the sunshine, hugging a tree, going to church, whatever works for you, do it. Let's keep your spirit and soul as comforted as possible. For 15 minutes a day, I need you to do something for your muscles. Get out and move. Practice good stress management, all that sort of stuff. Do your mind-body medicine, your I Spy, all that sort of stuff. For 15 minutes a day, I need you to do something. I need you to take a little bit of time to learn, because the only way you can be an advocate for yourself is if you know your stuff. And that means you got to be willing to read and all that sort of good stuff. And then for an hour a day, I need you to laugh, because laughter is truly the best medicine, and laughter reduces pain. So let's do that too. All right? All right, you guys. Donna, honey, it was so nice to see you. Big, giant hug. Big, giant hug. Everybody, be well. And we're going to say goodbye to YouTube.